Welcome to what is actually our last meeting in public of the Norfolk and Waveney ICB and the Suffolk and North East Essex ICB. We're today meeting in common, in public, not a public meeting, but a meeting in common in public. First of all, housekeeping. Now, as far as we know, there are no fire alarms scheduled. So if the fire alarm does go off, we're going to assume it's the real thing, and we'll have to evacuate as quickly as we can. And the fire exits are indicated all the way around the room, as you'll see from the green signs. Actually, one of the best ways out is the way you came in, to be honest, and the assembly point is near the aircraft, and I've forgotten what it is. Is it a Typhoon? I've forgotten now. Oh, is it? Right, okay. Anyway, that's where the assembly point is. And just a reminder that we are live streaming, so we've got a bigger public audience. We've got some guests present, so welcome to Susanna, Philippa, Helen, and other colleagues who I will introduce as we go through. We've got some apologies. First of all, Lisa Nobes, but Karen, you're deputising for Lisa, aren't you, today? Ewan Cameron, but we should have Nicola. There you are, Nicola. Thank you. Apologies also from Frida Barty, Moira McGrath, and Kirsten Alderson. Before I go to the agenda proper, a quick thank you before we start, really. First of all, to Emma Ratzer. Emma left the board on the 27th of February, so thank you to Emma for everything she did for the Norfolk and Waveney ICB in her time on the board. And actually, this is the last meeting for Hein. Where's Hein? Thank you, Hein, for Kathy. Where's Kathy? Got you. And Chris. Oh, you're all over there. You're sitting together. There's an escape plan there, isn't there? But thank you to Hein and Kathy and Chris for everything you've done for both ICBs, and indeed the working together over the last 12 months has been really appreciated. Now, as far as I know, we are quorate, and I don't know whether Heidi's with us at the moment, but Heidi told me that we were. Oh, are we quorate, Heidi? We are quorate, so confirmation of quoracy. Moving on to questions from members of the public, we've actually got 5. 4 of them are directed at the Suffolk and North East Essex ICB, and of course we are meeting together in common today. What I'm going to do is take those 4 questions as we normally do, normally in inverted commas, at the end of the meeting today. But we've got one question which is directed particularly to the Norfolk and Waveney ICB, which we're going to take now. And this is a question from the Save Benjamin Court campaign. And Martin, I'm going to go to you to ask that question, so all yours.
Thank you, Chair. I'd like to also thank ICB, and please pass on the thanks to the staff at the ICB for accommodating us here today. And please pass on our thanks as well to the County Hall staff for accommodating us, because we've got a lot of us here today and admit the efforts that they've made. So we've got a question which I'll read out. I'd like, just before reading that out, just to say one thing that was sent to us this morning, to give a context for what the question. This was from a member of the public who said, I live in Cromer, and last year I spent 8 weeks in hospital, 5 weeks in Norfolk and Norwich, and 3 weeks in Royal Papworth Hospital, including 2 heart procedures at Papworth. In early October 2025, I was discharged in a frail state, and so far I've received no hospital-based or community-based rehabilitation, apart from some helpful support from the community dietitian. Physio and OT support has been completely absent. 2 appointments made for assessments and both cancelled on the day they were due. I've now heard nothing for 5 weeks. This is care that would have been supplied at Benjamin Court, local and accessible. In the meantime, I'm getting weaker and less able to help myself. I despair. Well, I thought I'd just say that for context. so we understand the seriousness of what we're asking. I'll read the question out now. The post-hospital reablement service at Benjamin Court was closed in July 2023 with no consultation, and the site remains in great condition, albeit empty and mothballed, of delayed discharges of patients from hospital. In 1 month alone, September 2025, some £2.3 million was spent on keeping patients in hospital who were ready to be discharged at the 3 district general hospitals in the Norfolk and Waveney area. This, of course, has a knock-on effect on hospital admissions. In just 1 week, ending February the 15th, 2026, 83 ambulance shifts were lost at Norfolk and Norwich Accident and Emergency due to delays in transferring patients. In the 12 months from April 25 to March 26, delays at Norfolk and Norwich resulted in an extraordinary 2,328 lost ambulance shifts. Those are by far the worst figures in the whole area covered by the East of England Ambulance Service. The huge pressure on hospitals nationally as well as regionally has prompted the head of NHS providers to call for the government's much vaunted policy of neighbourhood healthcare to be turbocharged, a call we fully support. Yet Norfolk and Waveney Integrated Care Board, as we know shortly to be merged with a sister organisation in Suffolk, has up to now refused to look at an obvious solution right in their patch, Benjamin Court. We understand from our local MP that government ministers are taking an interest in health services in North Norfolk, which has the oldest demographic in the country, and particularly the future of Benjamin Court. So accordingly, we call on the ICB to follow the lead taken by University Hospitals of Leicester NHS Trust, who opened a 25-bed post-hospital rehabilitation unit to ease pressure on beds. We would ask that in any review of neighbourhood health services in North Norfolk, that you urgently look again at Benjamin Court and reopen it as an NHS hub to ease the crisis in hospital discharges and provide a vital health facility for the people of North Norfolk. We would also ask that you fully engage in a meaningful way with the local community about the way forward, and the Save Benjamin Court campaign stands ready to fully contribute to such discussions.
Martin, thank you very much, and that was very, very clearly put, and the sentiments behind what you said also came over very, very clearly. Thank you also for the context at the beginning, very helpful. A response from the ICB. Mark, can I come to you, please?
Absolutely, and thank you, Martin, and thank you all for coming today. I know I've met many of you before, and it is good to see you here. But first thing to say, I think, is a big sorry to hear the experience of the colleague that contacted you. Please do let us know the details, because that's not the service that we want to deliver to our residents. So if we can help there, I would be very keen to. Long question, but trying to pick up some of the key points that you've mentioned. We are committed as an ICB to work with you, with partners across the system to improve health, well-being and care of the people in North Norfolk and across the whole of Norfolk and Waveney. That we've always been that way, and we are absolutely committed to do that in the future. And I'd like to do that with you going forward as well. You made a point about the government direction, the focus on community neighbourhood. We warmly welcome that. I personally think that's absolutely the right direction of travel. With that particular focus on preventing frailty and supporting those who are frail. I think there's a lot more that we can do, and that's what I would like us to do working with you in the future. We're also very supportive of the ambition to shift care out of acute hospitals and into community to create a new neighbourhood service. I think that's very exciting. I think that's going to be presenting great opportunities for us all and for our population to provide better services and better outcomes. But we don't want to do that alone. We want to do that with you. We're also very conscious that Benjamin Court has provided very good services in the past, and we know it's really valued by residents. I'd suggest there's some excellent facilities right across Cromer and North Norfolk. And given the context of the new NHS 10-year plan, I think, since we last had detailed discussions on the subject, I think the world has moved on a little. So I would warmly welcome, Martin, I know we talked a little bit about this before, an opportunity to meet with you and spend more time looking at some options, because I think there are new options as the world has moved on since we last met. But once again, thank you. We are listening. We are listening as an ICB, and we do want to work with you.
Mark, thank you very much. Martin, would you like to respond to that?
Yes, I would like to respond, and I must admit, very pleased to hear from Mark what I'll say quite honestly, is a very different tone from what we've had in the past. Not from Mark personally, but from this body. And certainly we very much welcome the chance to be involved in discussions about Benjamin Court and the way forward in North Norfolk. What I would say, though, is that if the statement that I read out at the start means anything, it means that this is an urgent issue. We do not want to be wasting time. We don't want to be in the position of somewhere like Lowestoft Hospital still sitting there unused after all this time. We want to crack on with this. Benjamin Court is there. We've been told that it's in a good condition. It could be ready to be used really soon. So yes, please, we want engagement. We welcome that, and we really look forward to being able to get on with it soon. Thank you very much.
Martin, thank you very much.
I'd like to say thank you to everybody who's come today as well. Well done. You're the reason why this campaign keeps going. Thank you.
Thank you. Mark, I think arising from Martin's question and follow-up and indeed your initial response, can we take it as an action that you'll pick up with Martin and indeed the campaign team as soon as you can post-meeting?
Absolutely. Well,
Okay.
very happy to do that. We'll email in the next couple of days. Thanks.
Okay, thank you very much. Thank you. Appreciate it. Did you want to come in again, Martin? Are you happy with that?
I think that's the way forward. I think we've all agreed.
Yes.
That is a way forward. I mean, we're a long way to go, but we've got somewhere. And the main message is don't give up. We haven't given up, and we're not going to, I can assure you. Right, thank you.
Wonderful. Thank you very much. Now, Martin and colleagues, you're welcome to stay, of course, because it's a meeting in public, but you're also welcome to leave if you'd like to. What I can do, shall I adjourn for 5 minutes to give you time to leave? So a 5-minute adjournment, and then we'll pick up again. Okay, thanks very much, everybody. let's pick up with our agenda in the normal fashion. So we're actually on to item 3, which is minutes of the previous meeting. So for approval, first of all, the minutes of the 27th of January 2026. Now, there are 10 pages there. I'm going to take them en bloc if I can, but with the exception of 2 items which have been raised with me. First of all, you've got a point as well. I'll come to you if I may, Howard. Let me deal with Frankie first. So, Frankie, you've got a point that you'd like to raise. Over to you.
Yes, there was just a minor error in the wording of the minutes around mental health liaison versus mental health emergency departments, and Dr. Sethi has kindly provided an updated form of words to be included.
Okay, and that amendment will go on to the top copy that will go on file. Okay, and Elaine, I know you had a point about just clarification around effectively delegation of assertive outreach to the Quality Committee, didn't you?
Yes, so we did discuss it, and it was minuted that going forward, the oversight on the next steps regarding assertive outreach would be picked up through the Quality Committee.
Yeah.
So that is being put as part of the forward agenda, and we'll be discussing that in more detail next month.
So happening, in hand and happening.
It's in hand and happening, yes.
Lovely. Howard?
Yeah, it was just paragraph 11.1, which is the finance report. It should just read that Norfolk and Waveney was forecasting a break-even plan after provision of £41 million of deficit support funding, not 40 million, as was stated.
41, not 40.
Yep.
Good. Good. Let's make sure we get that right as well. So, colleagues, with those 3 comment/amendments, are there any other issues with respect to accuracy in the 10 pages that colleagues would like to raise? Are we happy, therefore, to approve as amended by or updated with those 3 points? Are we happy to approve the draft before you of the 27th of January 2026 as a true and accurate record of the meeting and actions noted? Agreed? Lovely. Thank you very much. Approved. Thank you. Declarations of interest. Are there any declarations of interest or potential conflict of interest with any agenda item other than those of which we're aware? None noted. Thank you. Chair's action log, nothing to report, so I think we can move on from that. Let's then go to the matters arising from the previous meetings and the action log. As far as I could tell, they were all complete or not due or on the agenda, with the exception possibly of the addition we could add the action that Elaine mentioned regarding assertive outreach. But there's one update, I think, with regard to social and dom care flu vaccination. Can I come to you, Fran, for that?
Yeah, thank you, Chairman. Yeah, I just wanted a brief update. Is that Norfolk County Council has been running an internal communications campaign and an external one as well with our providers to encourage everyone really in social and domiciliary care to take up the free NHS flu vaccine offer, both nationally but also within public health. We have been funding flu vaccinations for staff who are not eligible for a free NHS vaccine. So we've been trying to promote that to everybody. 288 Norfolk County Council staff did take up this offer, but we do believe that's a significant under-claimed back. Also as well, we're not quite sure with the claiming if they put it on the right claim line, should we say, so it may have gone down as something else like a sundry or whatever. So we're not sure that that's a very accurate figure, but so we believe it's much better than that. So yeah, but also say with our providers, we've been targeted campaign there through the Winter Readiness Toolkit, Norfolk Care Provider Newsletter and Care Provider Bulletin. So we're doing everything we can to get people to do it. Unfortunately, it isn't mandatory for care staff, so, you know, and also the recording of that's not mandatory either. So we're doing what we can. Thank you.
Thanks for that update, Fran, much appreciated. So with that, colleagues, are there any questions from board members today with regard to the action log before you, which is now consolidated, Norfolk and Waveney and Suffolk and North East Essex. Everybody content that we agree complete or on the agenda or not due? Agreed. And is anybody not content? Do you have any accuracy points about the log itself? Are there any actions that you think should be on there that aren't? Otherwise, true and accurate record. All agreed? Wonderful. Thanks very much. In which case, then, item 7, the CEO's report. Can I come to you, Ed, please?
Thanks, Chair. It's always been a bit of an ambition to sit up here, like, you know, Fran Mark. So it's a bucket list thing. So yes, when I drafted my chief executive report prior to reading the papers, and I realised most of the things I was going to talk about is actually on the agenda. So I won't labour some of these points, but it's a really good agenda, I think, because there's such an emphasis upon population health and strategy and neighbourhoods, and that's how the ICB should be going forward. So looking forward to today's meeting. First thing I want to say is obviously a thank you to Amanda and all colleagues around the leadership of the organisational change process. We are in good shape now to launch on the 1st of April. It's still a stressful, complex process, lots of people going through recruitment at the moment, but we've kind of met our milestones, and I think we'll launch a viable organisation on the 1st of April, which is great. Equally, thank you to Susanna, who organised a superb Learning and Legacy event recently at Colchester Rugby Club. What was great about it is I think we had strong representation from people in Essex, Suffolk and Norfolk. So there was a little bit of looking back and celebrating, but also looking forward and handing over geographies, if you like, in the right way. So thank you for organising that, Susanna. The planning round is a tricky process, but thank you to all colleagues. I think it's been relatively smooth and purposeful here for Norfolk and Suffolk. We've got some good plans which we have confidence in. Clearly we still have to deliver them, but I think there's been a strong sense of alignment and collaboration in the planning round, which has been great. Equally, during this time we've developed strategies in our population health improvement plan, which we'll talk about today. So it's been a very productive time planning wise, and I think we've got a clear sense of purpose and direction going into 26-27 financial year. Equally, I just wanted to recognise the improvements in productivity across the local region. During winter, we saw a 3.1% growth of productivity across our providers in comparison to the previous winter. East, the ambulance service in particular, saw a 9.8% improvement. So I just wanted to recognise all the hard work at East. And just very locally here in Norfolk and Waveney, the use of repeat process automation in general practice saw the delivery of 1.5 million prescriptions as a result of using that technology. So all of these elements add into that improvement overall. So some great work on productivity, and just want to recognise how hard all partners and sectors are working. In terms of celebrating success, we did very well at the recent HSJ Awards. Our specialist obesity treatment service won the Virtual Care and Personalised Care Awards, which is a massive achievement. This is a partnership between ESNEFT, the ICB and Reset Health. And I guess the headline on this is that until recently, people had a 2-year wait for this service that wouldn't be delivered locally. So that to go around the country, they now have an 8-day wait, and it's delivered locally. So that's just fantastic. It's really highly innovative, and the great thing is we're looking to expand the benefit of this throughout Norfolk and Suffolk in the future. So it's a really perfect case study, I think, of modern integrated care. Equally, in the virtual care category, the Queen Elizabeth, the ICB, Norfolk County Council and Norfolk Community Health and Care came runner-up for the work they've done very innovatively around the discharge pathway in West Norfolk. And that's in the context, and I look at the data very regularly, is the discharge performance in Norfolk and Waveney is regularly in the top 3 nationally. So we're doing great work. I know we talk about this around at the Health and Wellbeing Board through the Better Care Fund, but I guess the common theme here is partnership and innovation delivers great results. So across health and social care. Equally, I wanted to recognise the award for Dr. Richard West and Dr. Daniel James from Woolpit Surgery in Suffolk, who have been recognised by the Royal College of GPs for their work supporting mental health in the farming community, where there's a particularly high suicide rate, and that's obviously an issue in Suffolk, but equally in Norfolk. So the work they're doing is really relevant and very important. Final 2 things is we're really delighted for the Cardinal Medical Practice, who have now purchased the Inkerman pub in Ipswich opposite the site, and will be significantly expanding GP services there. For people that are less familiar with Ipswich, it's right in the heart of central Ipswich. It's a very obvious site next to a roundabout, and was originally the home of Ipswich Town Football Club. So there's quite a bit of heritage there. So very exciting for the community and for the regeneration of the town, plus for access to general practice. So thank you to all colleagues in the estates team and Maddie's team and others who have got this over the line. It's been quite a challenge. A year ago, I promised there'd be spades in the ground, and the BBC ran with that. So I'm quite relieved that there are going to be spades in the ground a year later. Finally, the National Neighbourhoods Guidance has been published, which we will bring perhaps to the future board. I think we have been quite well cited on what it was going to say, and I think our plans are aligning well behind it, but clearly that's going to be a huge area of focus for the ICB and all partners in Norfolk and Suffolk.
Should we put that in the forward planner, Ed?
Yeah.
Yeah, okay.
And the final one is around lung cancer. So Frankie's going to give some good news around lung cancer.
Right. Okay, over to you, Frankie.
Thank you, Ed. I feel a bit cheeky hijacking your moment, but I received some news this morning that I thought was just so good I wanted to share it with the board. We've reached a huge milestone in the project in Great Yarmouth and Waveney, as today we have diagnosed 100 people with lung cancer through proactive screening of high-risk people. So these are asymptomatic people who we identified using data as at high risk and have been found to have a lung cancer, 66% of which have been found to have it at an early stage when it's most treatable. So this is really fantastic news, I think, prevention in action.
Thank you, Frankie, and thank you, Ed, for your report. There's a lot of good news there, isn't there? We've got to make sure that we ensure that that good news gets out to the public, and that it's not all bad news out there. It doesn't mean we haven't got anything to do. We've got a lot to do, but there is some great work and some great foundations on which to build. So thank you, Ed, for that update, and Frankie, and thank you as well, as you said, Ed, to all the team. It's a team game, isn't it? So thank you to everybody who's contributed to what Ed was able to update us on. Any questions for Ed with respect to his report? Otherwise, received and noted, with thanks to all. Okay, thank you. In which case, then let's move on to item 8, the ICB transition update. And Amanda, I think I can come straight to you for this one.
Whoops, thank you. I'm focusing first of all on the transition relating to our staff, our people, and then I want to update on the broader transition relating to all things governance as we move quickly to the 1st of April. So in terms of our workforce update first, as Ed mentioned earlier on, we continue to work through our transition, our organisational plan, and to date we are adhering to the timetable that we set out many months ago. So in terms of an update, I wanted to just start with the voluntary redundancy programme and really inform yourselves that we are progressing well and we have the majority of leaving dates now agreed and arranged with our staff, and they'll be exiting our organisation from now until early summer. We have a few individuals that we're still working very closely with, and we're really waiting for pension estimates before we can move that forward. But I think all in all, we are supporting our staff with their intent to leave on a voluntary redundancy programme. And then moving to the broader organisational change programme, that's in 3 stages, as you would have heard me report previously. And with regards to stage 1, we are nearly completing that. We probably aim to conclude just before Easter, and that primarily is doing a lot of recruitment day in, day out, and we are nearly at 60% success in terms of recruiting to nearly 800 roles as we move forward. And then when we hit Easter, just after, we'll be moving into the final stages and recruiting to remaining posts at that point, and then looking to conclude with our stage 3 towards the end of April. So all in all, our organisational change is on track and working to our agreed timetable. With regards to our stage 1, I felt it was just worthy of noting that we have had quite a lot of appeals, 169, but I'm pleased to report to board that all of those appeals have been dealt with individually and all members of staff have received an outcome. So in terms of our appeals, all of that has been concluded and we're now moving through stages 1 and 2. So I think that's probably all I would want to say at the moment on our organisational change programme, but heading in the right direction and moving at pace every day. And then looking at the broader governance as we move forward to the 1st of April, things are progressing again to time and to timetable, and we are in a good place to create, hopefully subject to us receiving the establishment order, hopefully today. And that will basically then be formal abolishment of our Norfolk and Waveney and our SNE ICBs and give us the creativity of the Norfolk and Suffolk ICB. So that is awaited and we expect that hopefully today or tomorrow. But in terms of moving forward to the 1st of April, we are in good shape and we have a good constitution in place. We have our board membership now approved and we're now finalising the remaining appointments to that. And as we head to stage day 1, we have all of our plans in place. We have all of our mandated board and committees meetings agendas. So all in all, to date, we are heading in the right direction, subject to getting the formal notification. But I think I'll leave it there, Chair, but very happy to take any questions. Thank you.
Amanda, thank you very much. And I know before I open it up to questions, if there are any, I think on behalf of the whole board, I'm sure that you'll agree with me, colleagues, that we say thanks to all our staff for working through this process and recognising the challenges that everybody has faced in their different ways, but also thanks to Amanda and the HR team for a tremendous amount of work that isn't finished yet, but I think we've all experienced probably directly at times the amount of weekend and overnight working that's going on to keep this running to schedule. So thank you, Amanda, to you, and perhaps you pass on the board's thanks to the team as well as to all staff, of course. Okay, any questions for Amanda? I'll start with Fanwell.
Thank you, Chair, and thank you, Amanda. I second the Chair's comments on the work that has taken place, and hopefully, by the end of this, we will sort of have this organisation where we can move forward with the size of the teams that we. The particular question I have is that sort of during consultations and also in the People and Communities Committee, partners and staff always reminded us that we need to be aware of the fact that processes like that tend to, in historically, negatively impact on health inequalities, but also colleagues from with protected characteristics. I'm quite glad that full impact assessments have been done, but just to check whether there's we can provide assurance to the board that no issues have come out of those assessments that we need to be aware of moving forwards.
Thank you very much indeed. That is a really helpful question. And I can confirm, Fanwell, that we have actually kept a very close eye on that. And at a previous REMCON, we have reported that, and we will continue to report those statistics as we move forward. I would also like to add, actually, our staff networks across Suffolk and Norfolk have been invaluable. And they have been with us from the very beginning of the process and remain, actually. And we have continually listened to their feedback and their support in terms of how we move forward, particularly on managing the recruitment and the interview. So we are very much engaging and listening and more.
Okay, thanks, Amanda. Can I bring in Ed, please?
Yeah, one of the practical things that we did, which came out of a staff briefing that I was leading, is that we agreed that we would share all interview questions in advance of all the interviews, because that can create an inequality for people that have additional needs, let's say. So I think that's one example of how we've particularly thought about being inclusive during this process.
Yeah, thanks for that, Ed. Good point. Fanwell, are you comfortable with the response? In which case, I'll go to Janet.
Thank you very much, Chair. So I've had the pleasure of sitting on the Transition and Merger Committee alongside Hein, and also chairing the Remuneration Committee. And I just wanted to also reiterate the thanks from the professionalism of all the people involved in that, but also to assure the board that we have scrutinised quite long and hard on lots of these things, and we've heard lots of detail on the due diligence from operational leads, which have given us significant assurance. So thank you for that.
Thanks, Janet. Really helpful. Really helpful. We'll note that in the minutes. Any other questions or points, David?
Yeah, again, just from an assurance point of view, this has obviously been on Audit Committee agenda, and we probably spent about an hour on it last time round. So in both of the aspects that have been referred to here about the lead up to transition, and then also thinking about the type of risks and assurance that we'll need to keep an eye on as we go through the next 6 to 12 months.
Yeah, good. Also, well worth noting. Let's capture that in the minutes too. Very useful assurance. So, any other comments or points? Otherwise, we're asked to, with the comments made, receive and note. All done? Wonderful. In which case, thank you very much. I'll then move us on to the winter 25-26 update. Richard.
Thank you, Chair. So Mark and I will do a bit of a double act on this, so I'll kick off and then Mark will add in. So you've got in the pack a short paper which is an outline of our work today in terms of our winter planning and actually how winter has gone. And I'm looking at various provider partners staring intently at me, so I'm keen to hear their views maybe as part of the conversation after Mark and I have spoken. So as colleagues are aware, in both ICBs we submitted our winter plans to NHS England back in October, which were approved. And we've held around then an event in both systems to effectively stress test our winter planning. There was a number of areas that came out of that, as you'll see at section 2.2, refocus effectively our coordination structures so they were more robust, improve our use of hospital data, particularly pre-hospital, and strengthen our urgent care community response. As a result of that, we were fortunate to put in just under £750,000 additional investment to bolster our urgent care response services to provide effectively additional capacity over the winter period. It's fair to say it was a challenging winter. I think you'd be surprised if I didn't say that. And if you look at section 3.2, I think despite the fact that performance was above that of winter 24-25, we particularly had a number of challenges. So infection prevention and control was a particular feature for most of our hospital sites and partners over this winter period. Handover delays, ambulance handover delays, I think has been the main challenge across both Norfolk and Waveney and Suffolk and North East Essex in terms of the number and the time waited at our A&E departments to hand over out of the hospital, out of the ambulance into the hospital, and then factoring in staffing challenges, particularly during the winter period, across the service and the system, and as part of that just the general fatigue with the amount of huge effort that our staff have put in over that winter period to make our services safe and effective as they possibly can be. You'll see at section 3.3, those who like the data, that we've got a bit more information about how it's compared over the winter period in terms of our performance. And then moving down into section 4, as part of our measures, we've also have what we call an incident declaration process that we bolstered this year. And you'll see at section 4.4, there's a bit of a descriptor of what that means. And you'll see that there was 32 incident declarations across one or both systems over the last 83 days. And we've got a list of those. Within each, we coordinated, we supported as an ICB and either ICB system partners to come together around those and ensure that we came out of those with the lessons learned that we need. Speaking of lessons learned, just briefly at section 5, this is a bit of an interim update because we do an annual lessons learned, and obviously we're just coming out. I think we're not quite out of winter yet, so we are doing some lessons learnt. We do this every year, effectively to learn into our planning for the next year. We've carried out the SNE internal one last week, but we've got a system one on the 20th of March, and then the Norfolk and Waveney one is on the 16th. So that's really where we bring our partners together to do a bit of a deep dive in terms of how it's felt, what we could do better, what we did well. And if the chair's agreeable, we would be keen to bring the outputs of that to a future meeting of the board once it's gone through the appropriate sub-governance, so that we can effectively hear about some of the kind of key lessons that we've learned through that and some of the changes that we'd like to make in advance of planning for next year, which effectively will be starting pretty much straight away. Thank you.
Yes, never stops, does it? Richard, and thanks for making that final point. So you preempted one of my questions, really, whether we could put in the forward planner, because I'm sure the board would appreciate it. Once those system reviews are completed and you've been through due process, we can bring it. I suppose it might be a bit tight for the May board, but maybe July, possibly?
Yeah, no, May or July.
May or July. So if we could log that into the forward planner, that would be great. Thank you. Elaine.
Thank you for the update, and really good to see the focus on managing this so proactively. I just wanted to pick up on, you talk about the 3 areas to strengthen our preparation. The first one about refocusing command and control, I understand that. The second one, I was less clear on how that would work in practice. So it'd just be helpful if you could expand on how improving the availability and proactive use of pre-hospital data helps, if you could.
Yeah, I would say that we're richer in our data in terms of what happens within our secondary acute providers. What we've not been as successful in traditionally is getting the right inputs from primary and community. And actually, that gives us really good predictors of the demand pressures that are likely to come up through into acute care. So working with Maddie and Mark, we're getting better, I would say, at trying to get some of those predictors through from primary care in particular to help us in terms of our planning as we go through into the winter period. I would say, to be honest, we'll come on, I'm sure, with the population health management item later on. I think we are particularly strong, getting stronger in how we also use data to predict. So one of the things I want to do out of this planning for next year is how can we better predict? Because I think we often know what's coming. That, it's not significantly different each year, and how can we get better at predicting what we think is going to come, and how do we get that data to make better proactive decisions in terms of what we do.
Okay, thank you. Stuart?
Thanks, Richard. I think I talk about it a lot, so I appreciate I'm a bit like a dripping tap around this, but around one of the issues we talked about is infections. And particularly, obviously, if we've got high levels of infections in our community, it is going to be coming into the hospital. So I think we've been having discussions, and later on we've got the commissioning intentions where there's a reflection on making sure that we have IPC resources in to work with our providers. But I do think there might need to be a recommendation about how we collectively, as providers, commissioners and public health, all look at what we can do to support our communities to try and reduce infection, because I think there's a general issue here that Frankie and I were talking about that, actually inequalities generally features more even in infections as well. So I think there is something about actually how do we use our collective voices and our knowledge working across primary care, acutes, public health to look at how we can try and prevent community infections spreading, because I think it's going to continue to grow, and actually that's where we've all got a voice and we've all got skills, but I think unless we come together collectively, we're not going to be able to do much about that. And although we need good IPC in the acutes, we need to also try and prevent as well.
Richard, is that something that the system review would be able to pick up?
I might bring Karen in on that point, but absolutely, we're happy to pick that up.
Absolutely. Stuart, as you know, we've met fairly recently, a couple of months ago, and I'm really pleased to say that the structure has been amended, and we now have a very, very strong head of infection prevention and control. We're really pleased to report we've got 2 dedicated health protection nurses too, and our IPC lead. So very, very happy to continue and to work with you, Stuart, and our Norfolk colleagues around how we can work better together to prevent infection. So we have very good networks within our system between the acutes and the communities. We work closely with primary care and also with your good selves. So I'm very happy to meet with you and talk to you about that as we move forward. Thank you.
Thanks, Karen. Let's take that into the action log in appropriate terms for outside the meeting. Thank you. Did you want to come in there, Frankie?
Yeah, I was going to suggest that I'll also pick it up with our PHM team to look at targeting efforts at vaccination in cohorts of people who are less. It's something we have mused over in the past, but a very good challenge. Thank you, Stu. I'll pick that up.
Great, thank you very much. Mark?
Thank you. Just a couple of points to add to Richard's comments. It was very comprehensive. But when we talk about winter, there is often a misconception. It tends to focus on hospitals, on ambulances. I think it's just really important to stress that actually colleagues in primary care, community, voluntary sector partners who have played such an important role this winter as well. So great thanks to them. We know it wasn't a perfect winter, as Richard has highlighted, but it was good to see the improvement. The other point I'd like to make is both in the Norfolk and Suffolk plans this year, we're very focused on the alternatives to conveyance. And I think that's where we've had some real success this year. I mean, just to quote a couple of statistics, some of you will know about the Urgent Unscheduled Care Coordination Centre in Norfolk, and not in the report, but there were 19,500 ambulance dispatches prevented when we looked at more of an alternative model to support. And for those ambulance crews that did call the Unscheduled Care Coordination Centre to try and seek an alternative, 79% of those patients were able to stay at home. So that real prevention focus that we talk about, I think is a really good thing and should give us heart, particularly when we're thinking about what our plans are as an ICB going forward about prevention focus, more community resource, less shift. I think that gives us real hope. So lots of learning that we'll take from the future sessions, but I feel quite positive about this.
Yeah, a lot of nods around the metaphorical table when you were speaking there, Mark. So thank you for that. Board sentiment very positive on it. And Fran, if I'm not mistaken, didn't we hear at the last Health and Wellbeing Board about the UCCH best performing in the east of England? If I'm not mistaken, I think was the report.
I believe so, but I can't quite remember.
I think so.
Chairman.
Yeah. Okay. Nicola, on this subject, Nicola, yeah, do come in. Yeah.
Thank you. Yes, I was going to make the point about infections as well, because actually no matter how good our preparation is, it doesn't take much of an increase in infections to really derail all those plans. So that's something that we've reflected on internally within West Suffolk, and we're thinking, what can we do with our limited estate to try and protect people internally within the organisation, because of course it impacts on staff as well. So when we have high levels of patient infections, we also have staff outbreaks as well, and high levels of sickness absence. But I think the point about primary care and the wider system is really well made, actually, and I think there is an opportunity, if we think about other policy direction, other strategy changes around neighbourhood health and greater collaboration with primary care, I think there is an opportunity for us to bring primary care closer into that planning and response in terms of winter plans. And I also think that with a wider system footprint now, there might be an opportunity to better coordinate how do I describe this, ambulance deployment and diverts at times of extreme pressure, which still sometimes feels quite clunky, and people who, I know there'll be many people who do on-call rotas here and deal with that sort of thing. And despite having really good data now, which looks at all of the hospitals and to a certain extent sort of system capacity as well, that still feels like it could be smoother. So I think there's opportunities there as well.
Great. And again, lots of supportive nods around the table. Nicola, I also had you in my list. Did that cover the point you were going to raise anyway? In which case, I'll go to Nick, if I may, and then John, I'll come to you. Nick?
Yeah, thank you. I think so. Within the paper, it talks about the level of advanced coordination in Norfolk and Waveney between system partners. I just wanted to support that. I thought that the level of preparation this year, certainly from a social services perspective, that the ICB coordinated under Mark's team actually was really significantly advanced to previous years. Particularly the sharing of planning and some of the resilience events I thought were really, really helpful. That's not to say that there weren't challenging days during winter. There absolutely have been, but I think that gave us a much better understanding of each other's plans than we previously had. I guess there were two really brief pieces of learning. I think one I would say is actually the fact that we found time as a system in Norfolk and Waveney to do that work in advance I thought was really refreshing, and we should do the same this year. The other thing for me actually builds on a couple of other points that have been made. I think the more we can do to build into our overall planning and delivery approach services that then support in winter rather than winter planning just being a thing we do once per year is exactly what the Unscheduled Care Coordination Centre I thought brought. It's infrastructure that we have built that has then helped during winter, and the more we can do that, for example in our neighbourhood planning, I think is really, really welcome, then supported by the annual winter planning process.
Great, and lots of supportive nods there as well, so we'll take that as board sentiment positive. John?
Yeah, look, very briefly, I'm not going to be an echo chamber from the comments that have been made already because they're really sound, and it also be wrong to preempt the lessons learnt. But it has felt like this last winter we have worked so much better together. When Nicola says about the gold on calls, you know, they are normally dreadful things to actually endure, but we've had much better conversations. But the point I want to make is this, you know, we can look back and see how we can be better in the reactive space, but I think it was Richard's comment and Frankie's comment about the more proactive approaches we can take. I think this is where the data will lead us through neighbourhood health to really work with those members in our community, and we know we've got data which could always goes down to an individual basis. We can then start working and encouraging people to get those vaccination rates up, etc., etc. That, I think, is a really rich territory for us to step into, and that's where we should be leading on neighbourhood health to deliver with our partners and wider system partners to get this nailed, so next winter's even better.
This is great stuff, isn't it? We're going to be organised, we're going to be proactive, we're going to be system orientated, so this is really positive. Colleagues, we're actually only, have I missed, Adrian, sorry, thanks Richard. Adrian.
Thanks Richard. So Adrian, from an ESNIFT perspective, and indeed I think it's been a challenging year, and some aspects of performance have held up better than others. I mean, the challenge for us has been ambulance handovers, but you know, good performance on 4R ED performance, and I think that's probably down to the, you know, if you like, the full year effect of the new Ipswich ED facility as one of the reasons. I won't rehearse the other comments they made because they're all valid, but I think a couple of comments from me. One is I think we felt the benefits of our EPR and EPIC, and a much better way of diagnosing pathway issues that we could rectify. I'll pick on pharmacy as one example, where we found probably what we knew, but it was there in the data that we could prove that if we invest in pharmacy, we can have faster discharge and have that flow within the hospital. I think the other matter, I think we're getting better at the proactive side around the lesser acuity patients, but it's the acuity that I think is increasing and will increase year on year for the next decade plus that is becoming the issue that is actually coming into hospitals that I think we need to get our head around. And again, I'm interested in the work, you know, on population health management, how we can do something about that as well. That's more difficult, more challenging. We need to do the more proactive on the less acuity orientated. And just to refer to the other comments about planning, it sounds really odd, but we're starting again in April. Planning round over, things have moved on another 3 months. Seasonal variation starts again now, particularly with an emphasis on sort of the community investments, what can they do for the capacity plans, etc., etc. And I think this is going to be a theme right throughout. I think even every quarter, I think we're going to have to review again and again to keep us on top of our game. But I wanted to highlight EPIC, but also acuity is just going up and up. In terms of a lot of sicker patients actually coming into EDs now.
Thanks, Adrian. Points well made. Colleagues, that was a very rich discussion. Actually, we were only listening to you for an update there, Richard, but I think we've got a lot of positive sentiment and collegiate approach here, which is going to lead to better outcomes. Board members were asked to receive a note. We obviously have heard the discussion, and we look forward to the next report post-system review, Richard. Maybe May. If we can get it for May, that would be even better, wouldn't it? So look forward to it. Lovely. Thank you very much, everybody. In which case, item 10. So work well. Amanda, I'm going to start with you, but then you're in control of the speakers to follow. All yours.
Thank you very much, Chair. So I'm delighted to be joined today by two of my wonderful colleagues, Philippa and Helen, and they are going to bring to life in a moment a fantastic work programme that actually is being nationally funded by the Department of Work and Pensions and the Department of Health and Social Care, and that is really to look at how we can address the unemployment and really support our population as we move forward and increase their health by work. So I'm going to leave it there and enable my lovely colleagues to talk us through the Year Ahead programme. Thank you both.
Thanks, Amanda. So SNE colleagues may remember back in November you approved the work and health strategy for the ICB there, and Philippa and I have been working across the two counties to look at how we can improve health of working age people. And this national rollout of WorkWell has come at a very good time for us in terms of that agenda. So there's been 15 ICBs across the country who've piloted the WorkWell scheme, and it's aimed at people who are in work who are struggling to stay in work with because of their health needs, or who are off sick and need support to get back into work, or those that have really just very recently left work due to underlying health needs. And the aim is to provide early intervention, holistic assessment and personalised care planning so that we can support people both with their health needs as well as supporting them and their employers to help them return to work as soon as possible. This very much aligns with the Get Britain Working and Keep Britain Working papers, white papers that have been developed, and the localised Get Suffolk Working and Get Norfolk Working plans. And we're working in an integrated way with our local authority colleagues to ensure the crossovers and connections with other employment and skills and development work streams. So we are being given 3 years of funding, starting from the 1st of April, with the expectation that we have a universal offer available for all, both counties from November of 2026. So it's quite a tight turnaround. So there will be, in a way, 2.5 years of actual operational services in place. And this really gives us an opportunity to understand the health needs of our working age population as well, and work alongside them, so fitting into our sort of longer term strategic commissioning and population health approach.
Thank you. So as Helen's highlighted, this is a shared agenda. Whilst the ICB is the accountable body, this is very much something we want to develop with our system partners, particularly DWP, local government, voluntary sector. We were asked to pull together essentially our indicative thinking as to what we think a model could look like. It's not the final thing, but we have set that out in the paper. We developed up principles for the development of this work with our system partners, recognising actually that there's a lot of shared ambitions in this, and we need to make sure that we're not eroding what is already there, but we're building on that. We carried out some light touch system engagement to really start to understand where the opportunities sat and how we could align policy, but also understanding the existing delivery landscape and our cohorts. And the feedback we had really emphasised the delivery at a neighbourhood level, which is unsurprising, obviously, given the direction of travel, but that was just really helpful to really pinpoint that down. And we helped us understand where WorkWell can add value. And also how we can make this sustainable. Obviously, we have 3 years worth of funding, but we need to be thinking to the future and what this means for the ICB and our commissioning activity.
So in terms of the model itself, the national team has stipulated there needs to be a single point of access, so that may well be across both counties or each county having their own single points of access. And as Philip has alluded to, we want to try and integrate that into a system, because we've got many single points of access across the system. We don't want to invent another one. So looking again at how we can integrate with the opportunities we've got, and then looking at a more neighbourhood delivery model of work and health coaches and voluntary sector colleagues working together to really provide that personalised care that our residents will require. There will be a small clinical team that will facilitate any complex care or any clinical interventions that need to be put in place, as well as those work and health coaches who will have quite a broad competency level around employment, health, self-care, and also looking at the wider determinants of health as well, which we know are quite often root causes to some of the difficulties our residents are experiencing. And they will be there to advocate for the person, to link in with their employer, to have those discussions about reasonable adjustments and gradual return to work, so that there is an open conversation to support that person. So at the moment, from our conversations with system partners, we're looking at the potential of going out to procurement for a lead provider who may well manage that single point of access, but then have a collaborative commissioning relationship with many voluntary sectors who are in the local areas for the population's needs. So again, we'll be using the PHM data to facilitate that, as well as local intelligence around our communities. Year one, from November, we will very much focus on delivering that universal offer across the whole of the county. And then in year two, we will then look at having an enhanced pathways for priority groups such as young people, women's health, carers, groups that we're seeing that are more vulnerable to struggling with their health needs as well as working.
So, as we said, this is very much system-owned, so the governance will reflect that and also the co-design of that moving forwards. We are working through risks and considerations of this programme, and we do recognise there's a lot of change in the system at the moment, and we're working with the national team on this. They are also developing things at the same time, so it's a bit of a learning process with one another. So in terms of moving forwards, we will be engaging in wider system co-design. We're really keen to do this with organisations already operating in this space, people who are in contact with individuals who may be struggling with their health and falling out of employment, and particularly those with lived experience. That's really, really important to us. We know that there are a lot of existing networks and organisations who are engaging with people who have had their own experience in this space. We want to make sure we learn from that. And we also want to be making sure that we're engaging with employers and bringing them on the journey with us, because we do recognise the two cannot be separated. And so we're also working internally just to make sure, obviously, as Helen has mentioned, the timeline is quite short, making sure we're teeing things up from a procurement perspective, thinking about our information governance. It's a great opportunity for us to share data with DWP. It's not been done before, so that's quite exciting for us. So we will also then be going out to do some market engagement, so that actually when it comes to the point of procurement, we feel actually our providers have had the best opportunity to understand what it is we're trying to seek from this model. So we have had the exec management team have a HERDOC model today and have supported that, so we are seeking endorsement from the board. Thank you.
Great, thank you both. Did you want to add anything, Amanda?
I don't actually. Thank you very much, Chair.
Okay, and this hits the single biggest wider determinant of health, isn't it? It being employment. So lots of positives. Did you want to come in, Ed?
Thank you both. It's brilliant. I mean, it's a huge investment in Norfolk and Suffolk, isn't it? So that's the first thing to say. And the question I'm going to pose to you probably should be posing to myself, but what's the arrangements for accountability around this and evaluation? And once we've procured the service, how do we keep it visible, and how do we know it's successful, and how do we get the outcomes out for the community?
So we've been given some KPIs from DWP recently in terms of numbers of people going through the service and the outcome of that service, whether we are able to support them to remain in employment or not. There's also a patient satisfaction survey, and we need to be receiving at least 70% of positive satisfactions in terms of the service model and meeting their needs. There's a national evaluation going to be happening because obviously all ICBs will be participating in this, including randomised control trials and a quite robust research model. There's quite a lot of information we'll need to be feeding back up. But also we're working with the research and development team within the ICB to look at our own lens from a local level in terms of how we evaluate it and how that works in an integrated way with our neighbourhoods.
Oh, that's good. I know Ed would be very pleased to hear that evaluation is included in the programme. It's so critical, isn't it? Good. Did you want to follow up on that, Ed, at all, or are you happy with that? Okay, I've got a number of questions. I'll start with Fanwell, if I may.
Thank you, Chair. Thank you once again for all the work, and we're continuing to have conversations outside of this. I just wanted to touch on the point that you mentioned around engagement with employers. Now, we've been talking a lot to particularly the Suffolk Chamber, and one of the things that we've noted in the engagements that they're doing is that employers are talking about serious skills shortages locally, but they're also talking about particularly smaller employers who are saying we're struggling with understanding how we implement reasonable adjustments. And so because of that lack of understanding, sometimes employers actually then don't do what they need to do and they're asking for support. So I suppose my point is just to say, if we can look at how we can develop this in collaboration and in conjunction with our employers, so that we can then mutually benefit from that.
Yeah. Are we saying agreed?
Yeah, absolutely. And we're working very closely with our county council colleagues and growth and investment colleagues and adult skills as well, recognising there's a massive crossover with Keep Britain working. So, for example, in Norfolk, the Chambers of Commerce have been commissioned to deliver a piece of work. So all of this, there's read across it all, and we do recognise that none of it can happen in isolation. So excellent point. Thank you.
Great. Thank you. Stuart?
Sorry, I feel like I need to turn around, but so, no, welcome this, and just to say a massive thank you for engaging with us. I know my team have been working closely in Suffolk with ICB colleagues on this and recognising there's a huge amount of work going on in this place. I think the question kind of builds a bit on what Fanwell asked the question about, but recognising that we've got experience of things like Kickstart and other programmes which tries to do where employees have said actually, and including we as anchor institutions try and support and help people back into work, it can be quite a lot of work to support some people who are further away from work into that. And I'm just wondering whether the government's obviously announced some funding to support NEETs back into work and others, whether there's been discussion or recognition nationally that actually it can be quite a lot of work for businesses to be taking on people. It's the right thing, it's what we need to do, but also need to recognise that there can be further resource demands to help support people on that journey, and whether there's been any discussions nationally or whether any of that money can be used to support employers, particularly SMEs, in being able to recruit and take people on.
That's a really good point. And not only the amount of work, but it comes with a risk as well, doesn't it? Yeah. Helen or Philippa, do you want to come in?
Yeah, just to say, absolutely, that conversation has been recognised nationally. And just to say, we also do have Connect to Work, which is being delivered across both Norfolk and Suffolk. So Workwell will need to integrate with that offer, recognising that Workwell is quite short, sharp interventions, very much particularly through a health lens, and Connect to Work can provide that long-term support, working alongside both the participant and the employer. So I think in terms of what we have locally at our fingertips, we've got quite a lot. It's about how we make the most of it.
Okay, thank you. Great points, Stuart. Kathy?
Sorry, my question was exactly the same as Fanwell, so it's already been answered. Thank you.
Brilliant. In which case, Nicola?
Thank you. I was also thinking about our role as anchor institutions, and actually, the health and social care sector is a huge employer, so it was really kind of an offer. I don't know if there have been kind of formal approaches to, large health and social care employers locally, but we'd be really keen to support this. I think we could also learn a lot. We know, for example, when we look at our WDARES and other data that people with disabilities, staff with disabilities, don't have as good an experience in our workplace as other staff. So I think this could be a really positive mutual learning opportunity and support people to access and stay in work. And if we think again about kind of neighbourhood health, we need people in our communities to be contributing to improving health and outcomes. So yeah, an offer as well.
Thank you. Is that something you can pick up outside the meeting? Great, let's take that as an action. Thank you, Nicola. Fran and then David.
Thank you, Chairman. I think this is an excellent project, really, to take forward. I mean, as we've sort of mentioned, we've got Connect to Work here at the county, which we've been working with for a short while. But I do think there's lots and lots of things within this. I love the collaborative design. I think there's lots of things we can do within this. We talk about what I've got here, the district DWP leaders. A lot of them are actually embedded in help hubs or connected in with help hubs. So maybe that's another thing. We talk about district, we're actually mentioning the districts within this, but I think the districts have got a role to play as well within this. But I mean, also, you know, we often talk about, dare I say, making every contact count. Yeah. Well, actually, we have contact every day with people, and we can pick up people who need this help, and it's reporting it back. So as long as we've got clear reporting lines of how we do that to help people, I think we can help an enormous amount of people doing this. Thank you.
Great, thank you. And I'm taking that as agreed, noted. Thank you. David?
Yeah, I think we're hearing just what a complex area this is, and that if you sit with a work coach in a DWP job centre, and I'll declare my interest that I have sat with many in my time at the DWP, you realise that actually it's the tip of the iceberg is what someone might say is their health issue. It's housing, it's to do with where it's to do with a myriad of other things which currently work coaches don't have the breadth of skills to deal with, and often don't know how to signpost people in the right direction. They'll deal with one or two of the issues, but you have to deal with all of them at the same level. So I merely add a word of caution here about how we select our first 500 people to go through this process, that the obvious contact point is the DWP as they come through the door, if you get past the two guys who are protecting the work coaches. But I sense that I heard someone mention appointing a third party or an organisation to sort of manage this. I wasn't sure whether that was another body that was going to coordinate it or whether we were going to do it ourselves, because I can tell you that the DWP has had very poor experience through its health assessment side with whoever it has appointed in terms of getting people through the system and finding the right outcomes for them. So you may want to talk to me a little bit about all of this at some stage, but I just think if we're going to appoint someone, we need to be very careful that they come with the requisite set of skills, and that in appointing them, what they're not doing is we're not sort of robbing Peter to pay Paul in terms of resourcing that organisation. I'll probably stop there.
No, thanks, David. Do you want to come in, Helen? And, and also maybe there's an action to get together outside the meeting.
That would be great.
Yeah, over to you.
Yeah, so we're very much looking at one of our local providers being that lead provider, so someone that's already within the system who has a trusted role in terms of delivery of health interventions that has that track record that we can work with. So that will be part of the specification, who equally has a good understanding and connection with our voluntary sector partners at a local level, who will be able to support people. The national pilots have shown that 80% of the people actually didn't need complex health intervention. It was those wider determinants of health that were impacting them. And actually the pilots have shown, because it's mostly based people who are in work, it's the GPs that will be our main source when people come to them a fit note. But our longer term aim is that if we can support people at an earlier point when they're still in work, we can reduce the number of people that perhaps are falling out of work and then needing a work capability assessment and benefits later on. But the focus of this is around supporting health and well-being.
Okay, thanks. And we'll take an action for you to join up outside the meeting. Thank you very much. Thank you all. If there are no other questions, or am I missing? Oh, sorry, Elaine. Go on. Thank you. Thank you.
So I just wanted to reflect a bit more on the employment engagement piece, because I suppose thinking about it, so that's obviously an important other half of the equation. There can be so much done in health, but also there has to be a lot of support from employers. There must be a huge number of employers across Norfolk and Suffolk. So I was kind of wondering, how are you doing that practically to pick employers to work with so you can get the granular engagement? I suppose that you need to understand the complexity of getting people back in, because it just sounds like it could potentially be just this massive number of employers you've got to engage with in quite a complex, sophisticated problem to solve. So it's just really, well, understanding how you're doing that across all of them.
So I think there's going to be a mixed approach really, Elaine. So working very much with our chambers of commerce and some of our business networks, particularly for those that are working with SMEs, those small, because that we have the majority of our employers SMEs. But I do think some of it's going to be iterative. And when we're supporting people with a particular employer, there will be an education element in there and connecting with the employers to look at actually what else could we be doing to support your wider workforce and having a healthy workplace, and linking into the services our public health colleagues provide in that, in terms of advising on workplace health and health checks, etc. So I think there will be an initial engagement through some of our trusted networks, but then I think it will then need to grow over time, because you're right, there's so many organisations. Yeah. Thank you.
Okay, thank you. So, colleagues, I sense widespread support for this and enthusiasm with focus and development, of course, as Helen and Philippa have explained. We're asked to support the outline service model, support the governance framework, and the system integration approach, which of course is so key to us. Are we happy to support? Agreed. Lovely. Thank you very much. In which case, item 11, strategy and PHIP. Richard.
Thank you, Chair. So I'm conscious, apologies in advance, there's a lot of material in this pack. So I'm going to try and do my best at summarising where we've got to with it. But in all seriousness, we've done a huge amount of work, and a huge thanks to all of you, and particularly our staff who've moved mountains to try and get what I think, I would say, two comprehensive, I think well thought through documents in terms of setting what we want to achieve with and for our population over the next 5 years, and within the context of what we heard from Amanda in terms of what our staff are currently going through. So in terms of the context for this, you'll remember that the board received back in January copies in draft form of both the strategy and what we're calling the Population Health Improvement Plan. Effectively, it's our plan. So both of those documents, all ICBs in their new incarnation, so within our context, Norfolk and Suffolk have been asked to develop those, which is entirely appropriate as a strategic commissioner, that we effectively have a really clear strategy and plan for the next 5 years that guide our decision making, particularly our investments over the coming 5 years. I'm pleased to say that both of those documents were shared with our two health and wellbeing boards earlier in the month. Both boards were supportive of our approach and are in the process of writing a supportive statement, which is a requirement. Thank you, Stuart, for your help, and for Norfolk colleagues as well with that. At the same time, we've submitted those to NHS England. We've had support. There hasn't been anything substantive come back through the planning round to say that they aren't in line or they're not good. So I'm taking that as we can crack on. So therefore, we're presenting them both here today for agreement. In the appendices, you'll see there's the strategy as one, the PHIP for another, and a huge thanks to Simon, Chris and Amy and the comms team for their help, again in wading through the material to try and put together more of a front-facing presentation that I am going to come on to actually and use Amy's work. No pressure to just try and explain a little bit about what our intentions are, particularly with the strategy. And then you'll see also there is our commissioning intentions, which if you are really keen on reading everything, they do go into more detail specifically to each of our areas. So whether it's mental health, whether it's urgent emergency care, they will set out in a bit more depth what we're aiming to achieve over the next 5 years. So if colleagues wanted to move to page 120 in the pack, as I've just alluded to, this is the presentation that Amy and team have pulled together, which effectively sets out a summary of what we're intending to achieve effectively over the next 5 years up to 2031. And I just thought it was helpful, Jay, just to run through briefly some of those parts of that so you get a sense of what as a board in our new incarnation from the 1st of April that we're looking to achieve. So on page 122, hopefully the challenge absolutely resonates. And I'll be honest, we're not unique by any stretch of the imagination in terms of the challenges we face. And indeed, the Secretary of State in a speech earlier this morning talked very similarly about some of the challenges that we're facing across England still, even though we've seen some improvement. So we're still in the place where our communities, some of our communities have poorer health outcomes than others. Absolutely links back to the points Frankie and others have made around the need for population health management, the need for ensuring that we're targeting our support in a much better way. We know that demands on our services are growing, and as Adrian said earlier, the complexity and the acute nature of that is changing all the time. And we absolutely know, despite some improvement, which we'll see under the performance item later, our waiting times are nowhere near where they need to be. And we absolutely know that our long-term conditions is continuing to get worsen, and we need to be more proactive in support for that. I also recognise that our role is evolving, slide 123, as a strategic commissioner in our local system. And you'll see there very well set out some of the work that we've also been doing nationally to explain what is the role of an ICB. And really is that, in a nutshell, is on that slide, is to understand the local need, both data and lived experience. How do we triangulate that and develop a really clear narrative plan, strategy and plan, which we're presenting today. And then the hard work starts in terms of how do we actually do that? How do we commission that? That doesn't mean we get involved in the finer detail. That's very much a role for our partners on the board. But how do we set the conditions and how do we frame what we want to achieve and then let others innovate? As Ed said, innovation, I think, is the word, to ensure that we can deliver those better outcomes for and with our population. And then we've absolutely got an important ongoing role to check it works. And traditionally, we've not always been good in the NHS, I don't feel, at actually understanding what we're actually delivering is actually having an outcome improvement. So are we actually delivering for the population what we've set out in our strategy? And that's going to be a much bigger feature of, I think, the work of the ICB, and indeed has influenced how we've structured the organisation moving forward. So you'll see that we've got, I think, a very bold ambition that Norfolk and Suffolk residents live longer, healthier, happier lives with access to safe, joined-up, patient-centred care. And we've framed that around 4 ambitions, and they're very much aligned with the government's ambitions as set out in the National 10-Year Plan, from sickness to prevention, care close to home, analogue to digital, and really importantly, and links to the previous item our Mandarin colleagues presented, around our role as an anchor institution in social and economic development. We cannot do this without continuing to play a significant role in supporting the wider outcomes for our population, not just health. So how are we going to do that? You'll see on slide 125 that hopefully this looks very familiar for most colleagues. We have continued and we've really embraced the fact that we want to use the live well domains. So they've served, I think, the test of time for a number of years in our local systems. And this is the way that we are framing all of our commissioning programmes, and it's had an influence on how we're structuring as an organisation. So effectively, you'll see within the plan and the commissioning intentions, under these 6 headings, from start well through to die well, exactly what we're committing to for our local population, working with all of you on the board to try and deliver those on the next 5 years. And then just moving on to slide 127, you'll see that we're absolutely holding ourselves accountable as a board to some very aspirational outcome measures that absolutely we've got the next level of detail down with the team that we've pulled together around what are the indicators, both from a data point and lived experience, that we can hold ourselves accountable for over the next 5 years to demonstrate hopeful delivery, and when we're not delivering, why we're not delivering, and that we can take corrective action to ensure that we get back on track. And I think it's important, as we say on that final slide, 128, we can only do this in partnership. As Ed, I think, has said a number of times, that is absolutely a theme, I think, of the new ICB, that we can only deliver with you all and with all of our population to deliver these outcomes and these ambitions that we've set out. So I'm really pleased to suggest to the board that we endorse both the plan and the strategy, and then we can get on and deliver. Thank you.
Richard, thank you. So, Fran.
Thank you, Chairman. I just wanted to say that it was very, very well received at the Norfolk Health and Wellbeing Board. I mean, all the partners were on board, and I think that's a really important point, really, looking forward, as you say, about having that partnership working. I particularly like, and I mentioned it at the board, the strategy on a page. I think that's really easy for people to see and understand, and I think that's what we need to do, because often it's fighting your way through the mire, really, to find out what this actually means. And for me, that's very simple and easy. So I like that. The only thing, I mean, I wanted to say, maybe a spanner in the works, but obviously we've had a announcement today about the unitaries. So we have 3 unitaries for Norfolk, and I'll let whoever else wants to speak about Suffolk if they do. But for Norfolk, there's 3, and obviously we're talking about the places here within the paper, and I think that's something we will need to revisit. That's all I want to say. Thank you.
Yeah, agreed. And Elaine?
Yeah, so I thought there's a lot of really good direction in both of these, and I think what was particularly good to read is that focus on health outcomes and having metrics around those and starting to be really specific, which was good. I also thought the engagement plan was good to see that a real open, transparent discussion with the public and getting feedback as well. So it's not about broadcasting, it's about a proper dialogue and proper communication, which looked really promising. So for me, it came across really well. But as you say, it's getting into delivery next. But for me, read really well.
Thanks, Elaine. Stuart?
And I've said it all the way through. Thank you for the engagement with us as part of the development of that and listening to that. I think one thing I want to pick out, and it gets a bit more technical, but we start talking about things like allocative efficiency within the plan, which is about how we get best value from what we spend our resources on from a health outcome perspective. Is there plans in the future to help the board around some development sessions around what health economics and around some of these things? Because ultimately we are here to get the best outcomes for our residents. We are going to have to make some difficult decisions. The cost of new treatments, all the rest of it are going up, so we need to be thinking about how we optimise the best outcomes overall. So I think it would be helpful for the board to probably have a development session around that, because it starts to move us into a different way of thinking, and trying to understand that would be helpful, I think.
That sounds like a really positive suggestion. Are you up for that, Richard?
I could give a firmer commitment to that. So with my other hat on as National Director for Strategic Commissioning, we are looking to roll out a board development programme for all of the 26 ICBs. So that's going to be a phased rollout over the next financial year or so, and we'll be seeking expressions of interest from ICBs to put themselves forward for that. Notwithstanding that, realistically, given we've got 26 ICBs and that will take some time to work through, we will be developing something locally based on the national work that we've been doing.
Great, let's put that into the forward plan. Thank you. Ed?
Thank you. I mean, it's an outstanding piece of work, but plans will need to evolve and adapt. I'm just thinking about the global conflict at the moment, and, you know, if, heaven forbid, we're drawn into war, just think about how a plan might evolve in terms of a health response to that, and whether we can start to anticipate some of the implications of the next couple of years.
I suppose the reality is, just reflecting on that, if I may, on behalf of board members, a plan's only as good as it is on the day it's written, and they're always subject to review, continuous review, aren't they, Richard?
Yeah, no, I should say at the outset, actually, look, this is not going to be set in aspic. This continues to need to evolve. So it's an ongoing, evolving, sorry to say, strategy and plan, and it's formally annually refreshed. But we'll absolutely need to continue to look at events locally, nationally, internationally, and the impact they have, as Ed's alluding to, on us. I think we've got, at the moment, a clear direction. I should have also mentioned that within this, we've also got 8 themed areas that we're also looking to really prioritise, with some investment that Howard and our finance director colleagues have agreed that we can put towards this plan. So you should start to also seeing some kind of tangible outcomes of this relatively quickly in terms of business cases coming forward. And I know care management service is one of the areas that we're going to be talking about later on in agenda, some of the work we're doing in neighbourhood health. So there's some absolute immediate tangible areas that we want to start moving forward on.
Yeah, thank you. Okay, colleagues, we're asked to approve the strategy and the plan with the points noted in discussion, and that we will review at least annually and subject to events. Are we happy to approve the plans to 5 years to 2031? Agreed? Lovely. Thank you very much. Now, if we'd been ahead of time, I was hoping to offer you a tea break, but actually we're dead on time. So I'm keen, I know we're all keen not to finish late. Are we happy to keep going? Yep. In which case, Frankie, am I coming to you for the Population Health Management Annual Report, please?
Thank you very much, Chair. So you'll notice we have two reports from the two ICBs, which I think are both absolutely fantastic and really demonstrate the synergy between the two and how we're going to work in the future. The Norfolk and Waveney report we're going to start with, it's taken rather a delayed route to board, but we're very, very keen to share it in a way to celebrate the work and to thank the team before the closure of Norfolk and Waveney ICB. So the key features, we've worked further to embed population health management into routine practice. We've expanded our use of linked data, risk stratification, and targeted outreach. One of the tools we have in Norfolk and Waveney is the award-winning virtual support team, which I'm delighted to share is going forward into Norfolk and Suffolk. And this report flags a lot of projects that they've been instrumental in the successful delivery of, but perhaps not all board members will understand how they work. So just to give you a bit of a flavour, this team of this very small team of highly trained call handlers make proactive, direct contact. And in the last year, they've contacted over 60,000 Norfolk residents directly. And they've chosen those residents who are identified to have a specific need, to ensure that they are aware of and can easily access the specific support already available to them, be that a behavioural intervention to help with their weight management or their development of diabetes and prevent that, or whether it's access to home improvement grants, as we've done with some district council colleagues. And there's a lovely infographic on page 211 of the pack that I think demonstrates the spread of those projects. But Suzanne Meredith, who joins us, is going to pull out a few fantastic case studies to demonstrate it. And I am going to take this opportunity to embarrass Suzanne and thank her because she's actually retiring next week. And so she won't be joining us in the future. So over to you, Suzanne.
Thank you, Frankie. So, as Frankie has said, the report is a bit old now because it's taken quite a long time to get to board. And so I'd love to confirm that since the report was written, we've progressed all the work that we mentioned we were going to in the next steps. And so other projects such as the FH project, the several diabetes projects and the lung cancer project that Frankie referred to at the start of the meeting have all gone ahead since the report has been written. I'd like to just pick out two of the case studies, if I may, just to bring it to life. One of them is the Digital Weight Management Programme, and the board may have already noted that before, but I think it's really worth noting as a prime example of how our approach has really made an impact in the past. We worked with the NHS England. At the time, the Norfolk and Waveney ICB were the worst referring ICB in the country for the Digital Weight Management Programme, so we needed to do something different. And by working with the team and using population health management approaches, we really changed that around. We identified 4,627 people who wanted to be referred to this programme. We called them up, we told them all about it, they said yes. And as a result, we went into the stratosphere in terms of our results, and we went from the worst to the best in very short time. That was phase one of the programme, and since then we've progressed to phase two, and we've had very similar results again. So that was a real prime example, and that's on page 213 of the board papers today. You can see a graph there that's really got an amazing graph going up, showing you the progress that made. But I'd just like to highlight a very different case study that arose from concerns that our midwives had about inequalities in postnatal outcomes. And this was a really collaborative project working with local midwives, family hubs in Norfolk, and the Citizens' Advice in East Suffolk to support pregnant people who lived in the most deprived areas in our ICB. And this involved using the data to identify the people to contact and then phoning them and offering them support, linking them with interventions that were on offer, such as financial help, such as help with their housing and help with mental health support. At the time of writing this case study, we'd only contacted or referred 138 people. But since then, time's moved on. The project has been rolled out across Norfolk and Waveney. It's been evaluated in conjunction with the University of East Anglia. It's demonstrated very positive outcomes, and more than 1,800 families have benefited and been offered support in this programme. It's a wonderful example, I think, of how we can use this proactive approach and in the start well domain of our world going forward, delivering clear benefits for families and for the services that they've been involved with. In the group that we evaluated, just to finish, no one had missed an appointment. We had fewer preterm deliveries and more people were breastfeeding at first feed, which were all really, really brilliant outcomes for the people who normally live in deprived areas. So we believe this project has been extremely successful. And I don't believe that in the report it's done it justice, so I really wanted to bring it to life today. And thank you very much.
That's great. Thank you very much. Did you want to come back in, Frankie?
I was going to suggest that we pass to Richard, actually, to share the SNE before we take questions.
All yours, Richard.
Thanks, both. Just briefly then, we've also got a similar report from the team for the Suffolk and North East Essex Population Health Management Programme. And the good news is there's huge synergies and amazing learning from both the teams and both the programmes that I'm really heartened as we move together into the new organisation. So as you'll see, hopefully within the report, if you've had a chance to read, we've made significant progression, I'd say, from a really standing start only a couple of years ago. We've really moved forward in terms of our scale and maturity across the ICB, and it does feel like the approaches are well embedded within the way that we operate in the legacy ICB now as we move into our new one. And indeed, when we got our NOF1 announcement, our work on population health management was actually within that in terms of being a lead exemplar in improving population health management through the techniques and the approaches that we were taking in terms of our work. And I think, as you'll see within the report, in a similar way to what's just been said, the sheer volume of projects, programmes, pieces of work that we're now doing, which is actually based in the evidence base and the targeted work that comes out of our PHM integrated data set. I'd also pleased to say that we've now got 100% of GPs in Suffolk and North Essex bringing their data in. Not to underestimate, we are fairly unique in both Norfolk and Suffolk in terms of the work on this. So again, with some of the work I'm doing nationally, very few ICBs have managed to crack this, and it's not to be underestimated in terms of the kind of the power it gives us in terms of the work we can now do with and for our local population. And that's definitely going to be a feature and expectation for all ICBs as we move forward. And I think the other feature of the work we've done in SNE is the training and equipping of our staff base. So over 300 staff and partner staff have now been trained in the tools, techniques and access to that data and support in actually understanding it, so that what we don't end up is this being single point of failure with a very small team. We need to ensure that this gets out and permeates into our wider staff base in how they use this. And if you've seen, and I won't go through the detail, there's around 60 different projects and programs that are outlined in the report. For instance, around our type 2 diabetes risk strap work, which we've very much learned from Frankie and the team in terms of the approach on that. Digital weight management, both of us working together now on that. CVD case finding, the list goes on. So I'm really excited going into the new ICB that we've got some fantastic staff, we've got fantastic opportunities for this to become central to the way that we do our work. And in a similar fashion to thanking people, I also just want to put on record my thanks to Charlotte Minns, who has been an absolute star over the last 2 years to get everything set up, really motoring on this and really incredibly passionate about the difference using population health management can make. Charlotte's also moving on to a new opportunity promotion into the Cancer Alliance, and we wish her well in her future endeavours. Thank you.
Richard, thank you very much. Let me start with Ed.
Yeah, I'm going to build on my controversial statement just earlier, but the case study on page 218, Suzanne, around warm homes, I'm quite familiar with that because it's been to health and wellbeing boards, and it's, you know, absolutely outstanding. But fuel poverty is a real is an issue, but it's going to be a bigger issue. You know, anyone who's buying oil at the moment to heat their houses know that it's doubled almost overnight. So I'm just thinking about how we iterate our plans going forward. I think schemes like warm homes need to come to the top of the list, really, because it's going to be such a big issue.
That's a good point, isn't it? Frankie, do you want to comment on that? Suzanne?
So we are in the fortunate position, as Richard alluded to, we already have a 5-year population health management strategy. That the Norfolk one was only written about a year and a half ago. The SNE one was written about 3 years ago. So we've already set out very clearly where are the areas we can make the biggest difference, and the wider determinants of health and reducing inequalities are the areas we can make the biggest difference. So I absolutely agree.
Yeah, something to keep on the agenda there. Ed, did you want to add anything, Suzanne, or is that it?
Just like to also say we did that in conjunction with the district councils, and they were very, it was their work that we helped them with the data and identifying the people who would most benefit from those interventions. But we really need our partners in the room to really help us to do that.
Yeah, very current, very current. Thank you, Ed, for that point. Hein?
Yeah, thank you, Chair. Really a few comments. You encouraged us early in the beginning to provide the positives, and it's great to see these documents, both documents, provided in spades. And what I really like about it is, we heard from Richard, sometimes we struggle with identifying our outcomes, and I think that the strength of these programs is pointing to outcomes, providing a lens to health inequalities, very strong, prevention, and neighborhood working. And in that context, on page 222, and I'm a bit of a data nerd, I do want to give a shout out to the Population Explorer tool, because I think if board members would see, who've not seen it, the kind of insight you can glean from that, it's really amazing. So maybe for a future board meeting, a demo can be provided. Those were my comments. Thanks.
Yeah, thanks, Hein. The Population Explorer. Yeah. Okay, should we say noted on that one? Who have I got next? Howard. All yours, Howard.
Yeah, I'm a massive fan of this, and I mean, I think I heard someone mention health economics earlier and allocator efficiency, and at the heart, this is really what this is about, because if you're proactively identifying people at need, finding the right interventions for them at the right time, then you are going to improve your health economics and your allocative efficiency. That's what's going to happen, really. And it feels like we're at a brilliant place where we've got some fantastic capabilities and some really great learning between the two ICBs and some really great examples. And it feels like we spend a lot of time trying to prove to ourselves that this works. I think we already know it works. And I guess my challenge is, I think, are we being ambitious enough for the capability I think that we've got? And what do we need to do next to really lift this to the next level? I mean, you gave a fantastic example earlier around identification of people with lung cancer, and that's just, you know, it's amazing, isn't it? And how do we sort of lift this up to something that is much, much bigger, rather than doing lots of different projects and so on? How do we sort of really scale this up?
Yeah, I think Frankie's going to come in and tell us.
So I alluded to the fact that Suzanne is retiring next week, and Richard has alluded to the fact that Charlotte's done some amazing work in SNE. We have got a lot of change going on, so the teams are changing and resetting. However, with that reset, we also have opportunities. Derek is sitting towards the back there, our new Director of Public Health for Norfolk, who's only recently joined us, so welcome, Derek. And Derek Stewart and I have already met a few times, even though he only started last week, to talk about how we can really build on our partnership working with both public health teams and to help inform our population health management work. But I see a really obvious path, which is that we want to take the best of both. So where we have the amazing resource to use the virtual support team, we want to scale up those projects, and we want to do more projects using our data to tell us where they will have most impact. But equally, that's only one small part of our resource. And Hein mentioned our Population Explorer. We have multiple other tools as well. And what I think SNE has done really well at is actually really embedding the use of those similar tools, but at every level. And so we want to spread the virtual support team and the strength of that across Norfolk and Suffolk. But we also want to really ensure that every GP surgery, every integrated neighbourhood team, every PCN can use their own data, make it really easy for them to say, this is what's most important to my population, and this is what I can do about it.
Yeah, go on, Richard.
Just to add to that, I think also we need to get braver at, which is where I think you're pushing us, at making some bit bolder decisions around what we invest in. So if we know something's working in one part, actually why are we only doing it in one small part of the geography when actually, within reason, we could scale? And again, we've got a good example of that second plug care management service later on the agenda, which is likely to be something nationally that is going to be pushed forward, and we could be on the kind of the really leading this across England if we get behind something at scale. So I think we've got a fantastic opportunity, taking up Howard's challenge, to really get behind a small number of big things that we can do at scale, not just with the investment funding that I alluded to earlier, but more broadly with the potential we've got across the collective funding, whatever, of all of our organisations. It's just getting those things right, backed up with that data and the lived experience that our population is seeing.
Thanks, Richard. Derek, do come in, and welcome, by the way.
Thank you very much. I guess I just wanted to pick up on what Frankie had said. I've been sitting here, I've read the 800 pages as well. So I'm just letting it come in a little bit, but I have been a director of public health for a while now. And what struck me, and Stuart and I had a chat first thing this morning as well, is I'm coming into a system that I sort of got an idea of before I applied for the job, but as I'm finding out more about the system, if we aren't the best system in the country, we'll have failed in this space, it feels to me, because so far ahead of lots of other systems in so many different ways, there is a lot of change, and that's going to create a lot of risk. Losing Suzanne is going to be a massive loss for the Public Health Department in Norfolk. We are trying to replace, we won't replace Suzanne in a like-for-like way, but there's a real opportunity to build on that, and I'm really excited about that. I think in terms of how we scale up, it's a really important question. Firstly, we've got to make sure what we're doing works and is scalable, because sometimes things will work in particular populations, but won't work if we try to scale up, because it'll be a horses for courses argument. Secondly, we've got to be comfortable to try new things and fail quickly and move on to the next thing. And if we do that, then whether we call it allocative efficiencies or whether we talk of the finances, we're going to create space in budgets to do more and go faster and further. The final thing that strikes me is the old national lead for Public Health England used to talk about we need to focus on a home, a job and a friend. If we focus on providing for our population a home, a job and a friend, then a lot of what we deal with on a day-to-day basis is going to go away. And it struck me as I was reading the papers, a lot of these papers focus on certainly a home and a job, or they are key areas. One of the areas I think I'd be really interested in understanding a bit more is what the board's focus is about the friend part, because we know social isolation, loneliness in large rural coastal communities, absolutely vital. So I think that might be one we'd want to look at as well. Thanks very much.
Wonderful, thank you. Okay, colleagues, we're asked to note and endorse this annual report. I think, might we be wholeheartedly endorsing? I think a great deal of support. We take on board the greater ambition point that's been made, and we want to see further. We note the current progress, and we believe in that PHM can deliver improvements and outcomes and so on. We buy into it totally, but the board would like to see more faster, because that's the nature of the impatient board we've got, and we support that. Might be a future board dev on this, I think, maybe. Could be useful. Shall we see if we can log that into the forward planner as well? Although our forward planner is getting very heavy at the moment. I know. Anyway, with that, are we happy to wholeheartedly endorse? Great, thank you very much. Now look, from being ahead at the beginning to being on time when I last gave you the update, we're now 5 minutes behind. So we need to pick up and move forward speedily. With that, Karen, can I come to you, please, for the Learning from Lives and Deaths report? All yours.
Thanks so much, Chair. And I will be brief because you've all had the opportunity to read the report. So I'm pleased today to bring Suffolk's Learning from Lives and Deaths priority update for 2025-26. And it is, as I said before, a 6-month progress. There are 9 key priorities which were outlined in the report. And very much from this, it highlights the ongoing inequalities in health outcomes for people with learning disabilities and autistic people. The programme also reviews the deaths of people aged over 18 with LD&A, and all deaths of children, just for note, are, including those with LD&A, are reviewed through child death review programmes. One thing to really focus the mind is that persistent mortality inequalities remain. People within this group die around 20 years earlier than the general population. And I think when we look at this, it's important to remember that's a very key statement. I'm pleased to report in terms of the priorities, we've seen progress in the improved annual health checks and action plans. And as of January, we've seen an improved rate of the health action plans to 63.8. And also the plans have reached 97.7. We've seen some excellent work around education and workforce development with education sessions delivered in primary care with very, very much excellent engagement. We've seen peer educators active in GP schools and colleges, and we've also excitingly seen some co-produced resources. We know that there is a factor around respiratory illness identified within the mortality rates, and I'm pleased to say there's been a new dysphagia and aspiration pneumonia awareness produced with ACE Anglia and ESNEFT. There are very much community learning events, building better together, and as I say, it's made good solid progress. There are some delays in the priorities. There are 3 in particular, which is around the learning disability friendly GP kite marks, and that's been paused predominantly due to staffing, but there is a plan to restart that in April 2026. Also, there's been a slower uptake in the Oliver McGowan mandatory training, but we are moving towards a paid delivery model, which I think will definitely support an increase in that. And in terms of continuity of care, this is an NSFT-led priority, and they are working to develop a one-team model as we go forward. So the 9 priorities are very much outlined. As I say, it's important to see the focus very much looking at improving cancer screening for this group of individuals, looking at a 2-year campaign that's recently launched, Be Seen, Be Screened, Be Supported, expanding to increase breast, bowel and cervical and lung cancer screening, and very much about sharing resources across the region. So I think in summary, I would say that the Suffolk LDR programme has made really solid progress, particularly around the healthcare assessments and plans. It's about improving the quality of those, making it more accessible and increasing, as I said, cancer screening awareness. The 3 priorities that we need to do more work on, we've mentioned, and I think the report really strongly focuses on the ongoing need to reduce the systemic health inequalities that this particular group experience and the importance of lived experience, because we can talk about it, but we don't live that experience, and it's important we take that into our considerations in shaping future improvements. I'm very happy to take any questions.
Thank you, Karen, for that update. Any questions from board members? Otherwise, we're asked to note the progress. Noted. Agreed. Thank you very much. In which case then, neighbourhood health care and wellbeing. Maddie, are you doing a double act with Nicola? Shall I start with you?
Thank you, I am. It's a good job we rehearsed, as we're not next to each
Clearly,
other. Yes,
sitting close together was helpful.
Okay. Thanks very much, Chair. So I'm on slide 269 now, but I won't be going through all of them. So I'm really pleased to just share some context around our integrated neighbourhood teams across West Suffolk and Ipswich and East Suffolk, and really to describe the importance of this as the framework for the next steps that we need to take. And I hope in what we describe that you will see many of the themes that have been described by my colleagues picked up. So the mission and the vision for integrated neighbourhood teams and the outcomes associated with that, I think, are very clear in Suffolk, and they align directly to the plan which Richard set out earlier. We have 14 integrated neighbourhood teams now. I think the sun's shining in every one of those pictures. I'm afraid it's not always like that. So we have 8 in Ipswich and East Suffolk, and we have 6 in West Suffolk. What are they? They are our community service teams, our social care teams, aligned to general practice and working with others as appropriate to their neighbourhoods. And they've been doing this operationally for a number of years now. Many of them are co-located, many of them share a single team leader, and many of them have been through a number of development programmes together and work together. And they work together urgently on the day, and they do that very well. They respond in Ipswich and East Suffolk and in West Suffolk to the community services to our target, as you will have consistently seen in our performance reports. And they do it together, occupational therapists, wider therapists, district nurses and our social care colleagues sitting together as captains of the day to understand people's needs and to respond to them holistically. So they do it urgently, they do it well, they do it together. And the same applies to planned care, their daily planned care to individuals, for example, with diabetes, who need our support, and in meeting wider 18-week targets within the community. Not everyone knows it's an INT. If I say to some GP colleagues, how's it going with your INT team? How does that work? They'll say, who's that? I say, how's your collaboration with your social care colleagues and with your community service colleagues? And they'll say, well, that's good, or we need to do more of X, Y, and Z. So there's still work to do. They've also been using population health management, as Richard mentioned. The support that we've had has gone from top to toe and across our integrated neighbourhood teams, enabling people to understand the tools at their disposal and to design and to deliver programmes of work which meets needs in each of the different neighbourhoods that we serve. So that, I think, is the warm-up, and that's where we are. That there is a great deal of work that has been done to bring people together, to serve our population holistically through this team working approach. But now we need to take the next step. We need to move from a day-to-day working on urgent care to move from planned care positively and collectively to a proactive approach and to a systematic approach. And the Care Management Service is one of those opportunities, as is our work on end-of-life and palliative care, as is our work on diabetes and on heart failure that is supported through the National Neighbourhood Implementation Plan. So there are 4 programmes where we want to move holistically, universally, across our integrated neighbourhood teams, but in a way that responds to individual needs and meets them where people are in their neighbourhoods. So this is the next step. We do need to take this step whilst recognising there's still a lot of challenges, there's still a lot of work to do around digital integration, and the challenges are laid out on slide 276 around developing people further, looking at how we monitor, understanding changes in boundaries, understanding estates capacity, understanding the day-to-day financial constraints that we may have. But these are things now that we need to do alongside moving in a really universal way and the next step. So I'm going to hand over to Nicola now to talk about the Care Management Service. Thank you.
Thank you, Maddie. And thankfully we have rehearsed this because it feels like we've done this a few times now in a few different fora because people are really interested in this. Just to set the scene a little bit, you'll see from the slides that this has truly been a collaborative piece of work. So both foundation trusts, which people will be aware we're both acute and community providers, but also the Suffolk GP Federation and Suffolk Family Carers have been the core group in developing this model, working very closely with ICB colleagues, but also touching base with wider stakeholders, including the People and Communities Committee that we have taken this proposal to as well to get some feedback and to enable the co-production of this model. Just as a bit of background, about just over a year ago, the SNE Sustainability Review report was published, which certainly came to the SNE ICB board at the time, which was really driven by the kind of unsustainable future of the acute part of the health and social care system. And what I mean by that is that clearly, and it's still the case now, a lot of resources sucked up by hospitals. And yet we all know, and that's what we've been talking about a lot today, that what we need to do is get into that preventative space, that proactive space. And indeed, hospital is probably not where most people want to be most of the time or need to be in some cases as well. So it was a financially unsustainable model. It looked specifically at SNE at the time. This has now evolved into a Suffolk model because of the boundary changes. But it looked at that population, and what McKinsey found was that, looking at the data, that 1% of the population of SNE were using between 60 to 70% of unplanned hospital bed days, so using a lot of that resource. And so that's where the inception of the care management service was actually, if we work with that part of the population in a proactive way, how could we actually improve their experience of the health and social care system? And probably that's not spending all of your time in hospital. Then national policy caught up with what we're thinking anyway locally, because of course we've now have the enablers of neighbourhood health, the unbundling of the UEC tariff, which gives us a mechanism of whereby systems can actually invest in this sort of model. Now it may be surprising sat here as somebody from a foundation trust, because there are risks inherent in this too, particularly the acute part of our organisation, the funding of that. So one of the things I might mention later, and it's in the slides, is this has got to work. It's got to actually reduce the demand. Otherwise, we need to do what we've talked about earlier, make those brave decisions about understanding why it's not working, stop it, pivot, do something else. I won't go through all of the slides. Basically, this is an MDT approach. So the first thing is you identify the cohort. And again, what we're finding is it's about 61% of the population are using, 1% of the population are using about 61% of the acute bed days at the moment. You identify that cohort at a local level, and you work with them through a focused MDT. So nothing particularly different about that, you might think. However, in my experience, I've worked in community healthcare as well as acute for a long time, is we're not always that good at being data-driven in our approach. We often offer a kind of a universal service rather than targeting our services at a defined cohort of people. We're also working, we're looking at a couple of companies at the moment in terms of using AI to identify that cohort in the future. At the moment, we have to use historic data to find out who has used those acute bed days. What we want to do in the future is actually identify them before they start having those high levels of hospital attendances and admissions. And AI can certainly help with processing that huge amount of data and telling us where we'll get most benefit for that population. Also, it's a bespoke, personalised plan. So that plan is not a one-size-fits-all. It may involve the voluntary sector. Derek talked earlier about the importance of having a friend, that kind of impact of social isolation. What we know is whilst this cohort have a lot of comorbidities, the reason that they might go into hospital might not be because of the deterioration of their health. It might be because of carer breakdown. It might be because of other factors as well. Also, what's quite different is that involvement in the voluntary sector. Certainly in my career, I've never worked so closely with the voluntary and community sectors I have on this project, which has been absolutely fantastic. This absolutely can't be completely led by health, and that's been a real learning opportunity as well. And as I said, I will labour the point. This is required to demonstrate an absolute reduction in hospital activity so that we can release that funding. Otherwise, we're paying twice. We can't afford to do that as a system. So it has to work. We're absolutely committed to make it work, but we have to see the data as well. There's been a early implementation site for this in the west of Ipswich with that PCN that's been running since October last year. We're keenly awaiting the quantitative evaluation of that, so some data around that and the impact it's had, which should be available in the next couple of weeks. But I would, while we're here, just like to share a case study to bring some of this to life for you all. So I'm going to talk to you about a man called Robert, who's 55 years old. Robert has a diagnosed learning disability, he has epilepsy, and he has severe dysphagia, so he's fed with a tube. He lives in a residential home with 2-to-1 support, so two carers. He's a heavy smoker, and he's really fearful of hospital settings, and a lot of the work that's happened to date before the care management service was trying to actually help him stay at home, so that was absolutely intent, but because he didn't want to go into hospital. And the healthcare providers around him really wanted to support him with that, but he did have frequent crises, resulting in aspiration pneumonia, and whilst he was kept out of hospital for a certain amount of time, eventually actually kind of the paramedics were called and they'd be like, no, we're going to have to take you in. So repeated ambulance call-outs, long hospital stays, which was all contributing to kind of an ongoing cognitive and physical decline for Robert, and not a great experience for him. So what the care management service has done in this situation is the GP has been absolutely pivotal. And what I didn't say about this is that the idea of this is it is delivered through existing services, but through better coordination and through some dedicated time. And the GP who's been involved with Robert's care, who will talk much more articulately than me about this and much more passionately, said that it is the time. And you can't give that to everybody. We can't afford that as a system, but actually there are people in our community who do need that additional time. So that GP has engaged the residential home manager, Robert's longest standing carer, a social worker, Robert's advocate, and the specialist clinicians in the hospital as well, who actually treat Robert when he does get admitted. So all of those people came together for a 40-minute clinical review, followed by a direct patient assessment, which also took quite a long time. As I said, the consultant respiratory physician was involved in that as well. And actually, together they put in place a plan where there was home antibiotics and actually a reduction of some of the medication that Robert was also on. A lot of people are on multiple medications. There can be interactions, and some of those medications actually can make some aspects of care worse for people. So there's a real development of a personalised care pathway for Robert. Best interest decision making. So for example, so this is somebody who's tube fed, but food is important for other reasons. So a taste for pleasure plan was put in place as well. This is about quality of life, not just length of life or physical wellness. That plan was coded into the GP record with special alerts, special notes, and follow-ups were planned. So the impact of that, so there was a quantifiable benefit for Robert in reduced hospital admissions over a period of time compared to the previous period of time, particularly those triggered by aspiration pneumonia. Improved continuity of care, improved dignity, so care being delivered that was completely personalised and where Robert felt safest, which was in his place of residence in his home. And I think particularly that pleasure-based eating approach, which actually took kind of a step back to think about that for Robert. For the staff and carers, the feedback has been increased confidence and that they've got a clear protocol, clear plan to follow, so they feel okay about that, they feel safe about that. And the system benefits, so fewer ambulance call-outs, fewer lengthy hospital admissions, more efficient use of that specialist expertise in the hospital. So we're not saying we don't need that from the respiratory physician, but actually rather than it being reactive, it was proactive, and that really strong collaboration. So I'm going to just leave that with you, and I'm sure Maddie and I are happy to take any questions.
Nicola, thank you. Maddie, thank you. I'm just conscious of time as well, so we need to pick up speed, please. John?
So I'll be super quick. I want to thank Maddie and Nicola for that, because if you're not excited by the prospects of this, there's something wrong with you. Can I just say, though, and I think this is brilliant what's going on in Suffolk, just to give you confidence, Chair, that there is good stuff going on in Norfolk as well. We've got Test, Learn and Grow pilots. We've got the Great Yarmouth and Waveney as part of the National Community of Practice programme for INT. And only this morning I met with Maddie, Fanwell and Mark and others to make sure that we bring the 3 Norfolk places and the Suffolk alliances together. We'll share the progress. We will join up so that we can actually really motor on with this stuff, because it is exciting. Thank you, Chair.
Thank you for that, John. Thank you. Elaine?
We're just echoing that, because we did cover this topic earlier this month in the West Suffolk Alliance, and I think it was definitely one of the most engaged discussions we've had on any topic before. So recognising that there is still quite a bit of work to do, and I think the point you were making, Nicola, about that time that's needed and that coordination, some things to sort of think through how it gets managed practically, but absolutely the note from the meeting was a real positive step forward. So yeah, thank you for the update today, and also the one earlier this month.
Thanks, Elaine. Ed?
Yeah, we had a paper to the last ICP here around neighbourhoods and the natural neighbourhoods that have been agreed in Norfolk and Waveney. So we've got agreement on those neighbourhoods. I know there'll be lots of conversations now about how we bring teams together in those neighbourhoods. I think part of the learning from that you were describing, Maddie, is the development support for the teams. So I wonder if we haven't got a development programme under consideration for Norfolk and Waveney integrated neighbourhood teams, we should probably invest in one. I think it's mission critical, because teams grow and develop through learning, and having a protected space for them to spend time and to think about how they're going to work together, how they're going to support their population, will pay dividends. So just in terms of the investment pot, Howard and Richard and Frankie, I think we just have a think about that development. I know, Dave, you've been doing similar work around the interface between primary and secondary care and others in SNE. So I think that's one of the key building blocks.
Can we say yes as a board to that and throw it over to the team to figure out how to do it? Agreed. Thank you very much. Frankie?
Thank you. I just had one query and offer of help, I think, Nicola. When we talk about the 1%, it's really important to remember that this is a rolling 1%. It is not a fixed cohort of 300 people. It is, at any given time, 1% are the people most in need, not having their needs met, and so ending up using these hospital beds suboptimally. So I really, really welcome your suggestion that rather than basing on historic cohorts, because they will be wrong, and many of them are end-of-life patients as well. The idea of using AI to help that modelling and prediction, and I'm reminded of a fantastic visit we had with Breckland District Council recently, where they were talking about they'd used AI to identify people who are at risk of becoming homeless in the next 6 months, and it was extraordinarily effective. And so there are tools out there, and so my offer of help is to work with our innovation head to perhaps invite offers of people who might be able to come up with some help, because if we keep looking backwards, we're going to be targeting the wrong people.
Thank you, Frankie. So with that action, which the team are going to figure out, we do support, again, as a board, don't we? We're asked to note, should we say noted and supported? Agreed? Right. Okay, so we were 5 minutes behind before, now we're 10 minutes behind. So just a bit of meeting management. On item 16, the performance report, Richard, if you can be very brief and we go to questions as quick as we can, and maybe Amanda on item 18, the BAF, could we do the same if we can? In which case, item 15, finance report. Howard.
Thank you, Chair. I'll try to be brief as well. So I'll take both systems in turn and also provide an update on progress with financial planning for 26-27.
Position for Norfolk and Waveney ICB for this financial year. First of all, just a reminder that Norfolk and Waveney has a break-even plan after receipt of £41 million of deficit support funding, which is essentially spread across the Norfolk Group of Hospitals and NSFT. At month 11, the position for Norfolk and Waveney is currently sitting at 1.3 million deficit year to date, or 1.4 million favourable to plan. That's in line with the report I provided at the January board, whereby resolutions to the reported risk of a 5 million deficit at the Norfolk Group of Trusts had been mitigated following receipt of national funding for industrial action and also for PFI. The ICB position continues to be stable and on track to deliver plan following the mitigating actions that were taken earlier in this year to close the gap on our efficiency programme. So I'm pleased to report, therefore, that Norfolk and Waveney are fully expected to meet their plan for 25-26, both in aggregate and also by organisation. I'll confuse you all in a minute, but first of all, I'll cover the position for SNE. And for SNE, a reminder that we have a break-even plan without provision for of deficit support funding, and that plan is made up of a 20.7 million deficit at West Suffolk Foundation Trust, essentially offset by an equivalent surplus at the ICB. We have been reporting consistently this year that ESNEFT have been about £16 million off plan. Largely, we believe this to be a non-recurrent issue related to the intense efforts required to successfully implement the new EPR, and Adrian talked about EPIC earlier, in the trust, as well as the bedding in of some very significant investments, including the elective orthopaedic centre. I had reported to board in January that work was ongoing to provide support, including the distribution of system-earned incentive revenue funding to the ESNEF position, and that has resulted in now approved NHSE changes to organisational forecasts that you can see in the report. The revised forecast for ESNEFT is now 4.1 million deficit following that support, and need to advise the board that there's still a risk that that won't be delivered. So we are continuing to work very closely with the trust to resolve this issue and obviously ensure that ESNEF delivers its revised plan, and also that the SNE system itself delivers its plan for 2025-26. All other organisations, including the ICB, are tracking well against their approved plans and agreed revised forecasts. Again, just to confuse everybody with the beauty of NHS finance, I can also report that NHSE have recently approved distribution of unearned deficit support money that's been distributed nationally to both SNE and Norfolk and Waveney. So it's about 6.6 million to SNE providers and 11.5 million to Norfolk and Waveney providers. And that's been distributed providing they've met the requirements of delivering their in-year plan and have set balance plans for 2026-27. Only ESNEFT of the system of the providers within the two systems have not met that first requirement, so will not receive that funding. That really only provides a cash benefit to those trusts, but they are expected to improve their financial positions by the same amount. So I told you I'd confuse you, but anyway, therefore the SNE system will be expected by NHSE, bear with me, but with the SNE system will be expected by NHSE to exceed its break-even plan by £6.6 million, and Norfolk and Waveney will be expected to exceed its break-even plan by £11.5 million. So that aside, I am confident that SNE system will deliver its plan for 25-26, but there's still a little bit more work to be done with ESNEFT over the next few days. 2026-27 planning. So a reminder, I think, to the board that the funding for the new ICB is just shy of £5 billion, and that system control totals will no longer be a requirement from 2026-27, so that will fundamentally change how we report to board going forward. The new Norfolk and Suffolk ICB 3-year financial plans were submitted on the 12th of February. We were one of the few systems in England and the only one in the east of England whereby the ICB and all system partners submitted balanced financial plans, again, after the receipt of deficit support funding. We've also, as we've mentioned earlier, developed a £27 million recurrent fund to support reduction in growth of unplanned hospital admissions, and we're hoping that will help fund the care management service, for example. And that fund will grow to over 60 million in 2027-28. So we're just in the process now, Chair, of finalising contracts with our key providers, the initial deadline for which is the end of March. Meetings are in place this and next week to resolve any remaining issues. They look relatively low and small in value, so I'm expecting them all to be resolvable. We're obviously working on finalisation of those programmes to utilise that £27 million fund. And of course, we are now moving towards delivery with respect to the ICB cost improvement programme, which totals £101 million, a very significant proportion of which is, of course, related to that organisational change that Amanda reported on earlier. So I'll stop there, Chair, but in summary, both systems I'd expect to deliver for this year, albeit a bit more work to be done in Suffolk and North East Essex with ESNEFT. And we are in a good place, relatively speaking, with a lot to do for 2026-27.
Howard, thank you very much for that very clear update. Any questions from colleagues? Otherwise, oh, David, yes, go on, David.
You mentioned patient right to choose twice in the Norfolk and Waveney report, but I don't recall seeing any reference to it in SNE. Is it a Norfolk and Waveney thing, or is it just it wasn't budgeted for correctly?
So this is an issue related predominantly to neurodevelopment disorder activity, and it's an issue in both ICBs, but it impacted on Norfolk and Waveney to a much greater extent, largely because there was a bit of a delay, I would say, in 25-26 in terms of setting indicative activity plans with providers, but we've established that now for 2026-27, but it was a significant issue in both ICBs, yeah.
Thanks, so colleagues, we're asked to receive a note. It's month 11. Month 12 yet to come. Look forward to it, Howard, thank you. And then, of course, the whole of 26-27. Noted? Agreed. Thank you very much. Richard, performance report.
So I'll do the bridge version that I was planning to do, Chair, so you'll be glad to know that. So just briefly then, if we take similar fashion into Norfolk and Waveney, so overall, we're seeing committed efforts from all providers with some promising improvements, so particularly to pull out cancer faster diagnosis, outpatient waits, and the sprint-driven elective recovery, which in short is some additional funding that was made available to our trusts in both Norfolk and Suffolk and North East Essex to effectively put additional capacity in to reduce waiting times for outpatients and surgery. However, that's balanced with pressures in diagnostics, urgent emergency care, as we've pulled out earlier actually with the winter update, and some of our cancer pathways. So we're working intensely with all providers to try and stabilise that performance, support the recovery plans that we've got in place with each of our providers in Norfolk, and ensure that we enter into 26-27, the planning work that Howard and I been leading on with a really clear sense of how we're going to sustain some of the good progress that we've made. Similar story in SNE, so across most of the domains we've seen a committed effort to try and really progress against each of those major areas, whether it's urgent emergency care, cancer and planned care. We've seen real improvements in both trusts in RTT and diagnostics, particularly I have to point out West Suffolk with the diagnostic plan where we've seen a significant improvement, so well done to colleagues there. And also cancer performance at West Suffolk. We've also seen A&E performance, particularly at ESNEFT, in a good place, and also at West Suffolk, comparably across other partners in the wider region and nationally. Where we're still seeing pressures, again, similar themes around cancer pathways and urgent emergency care more broadly. So handover delays, as we've talked about earlier, is the big one that remains a challenge, indeed, in both ICBs. And then you'll also see at the final page in that pack, there is a short update around the sustainability review. So particularly the items that related to both ESNEFT and West Suffolk out of the work that we signed off as a board last year. And that's particularly focused around the collaboration, the productivity work, and also that's alongside the work that Maddie and Nicola updated on the care management service, which was a particular action arising out of that work for the ICB, and also as Amanda's updated on the running cost reduction programme that also sat with the ICB.
Richard, thank you very much for that. Colleagues, questions or points? Otherwise, we are receiving and noting. Done? Wonderful. Susanna, ICP report, please.
Okay, thank you, Chair. So I'm going to begin by talking about an update from Suffolk and North East Essex ICP, then move on to how we're moving forward. We're joining up and working with Norfolk and Waveney. So Ed's, of course, has already stolen my thunder on this. He's talked about the importance of teams growing and developing together through learning, and he's already mentioned the fact that the final meeting of the Suffolk and North East Essex ICP took place at the beginning of this month, and it was at that meeting that we shared for the first time a report of a learning and legacy exercise that we undertook across the Suffolk and North East Essex partnership, involving all system partners in reflecting and thinking about the learning that we wanted to take forward into new systems now in both Essex and also Norfolk and Suffolk. So the report, and there are copies, hard copies at the back of the room there, Heidi's got them, I'll sign them if you like, but it's a piece of SNE memorabilia there for you. But the report is very interesting, I do recommend reading it, and I'll point out a few things from it. But what the report does is it does, pull together the reflections of, more than 200 stakeholders locally in our system about, really what's most important about how we work together as a whole health and care system. The report talks about 5 different areas that it was felt that the integrated care system had an impact, a positive impact for the health and well-being of the population of Suffolk and North East Essex. Talking about how the ICS brought people together in new ways, sharing of resources and data, enabling new investment into the system, both from external sources and also internally, and the importance of hearing the voices of everyone in the system, and also the focus on improving outcomes. And I think I've heard all of those themes in today's meeting today as well. But more importantly, what the report talks about is the really kind of fundamental learning in the ICS, which I think I can essentially sum up in one kind of phrase, which I want to kind of you to remember in this room, which is that really it underlines the importance of remembering that we need to softwire our health and care systems. We need to think about the importance of proactively building shared purpose, shared narrative, relationships, actively redistributing power, and really focusing on culture and leadership as well. Now, as part of this review, we didn't just engage partners internally to the ICS, we also engaged 5 national organisations, all of which have expertise in the context of system learning. Now, all of these organisations included the King's Fund, NHS Confederation, Imperial College Business School, Ashridge Holt Executive Education, and the University of York. And all of them had frameworks that they use which sort of sum up their expertise around system learning and system leadership. And if you look in the report, all of them have provided external commentary on the learning from SNE and reflected on the extent to which the system reflected some of the key principles that are in those frameworks, and they're really, really important. So going forward, obviously the report was shared at that meeting, but we seem to be on tour at the moment, SNE. So today, Norwich, but I can tell you tomorrow, in actual fact, I think if it's Friday, Ed is going to be, I think, sharing some of the report as the keynote speaker for the EPIC conference, which of course involves colleagues from across the region. But in actual fact, in a couple of weeks' time, myself and Laura Taylor-Green are going to be sharing the report at the International Conference of Integrated Care, where we're part of a panel convened by the Nuffield Trust and the King's Fund and others about learning from integrated care in England. And this week, I've been sharing the report in Canada, in California, and also in Spain. So in actual fact, this report and the learning that we've had in SNE is really important. And it's really important that all of us hold it centrally as well. So in the spirit of that, as I said, we've really been joining up, and I think the commitment to system leadership has been very much the focus in Norfolk and Waveney as well, and was a key theme at the recent ICS conference that took place in Norwich, and we talked about. So we're going to take our first steps together in Norfolk and Suffolk by focusing on soft wiring the new Norfolk and Suffolk system. So after Easter, we're going to be releasing the details of our first joint venture, which is a joint venture between the ICB, Norfolk County Council and Suffolk County Council. So we're going to be holding a health and care expo on Friday the 3rd of July. It will be at Newmarket Racecourse. It will have the key theme around rural health. It will feature all sorts of things, including, I'll say no more, celebrity appearances. And also it will include our very first Norfolk and Suffolk Health and Care Awards as well. And I just want to say thank you to our non-executive members of the board who are going to be helping us with those awards judging panels and taking that forward. So thank you very much. That's my update.
Susanna, thank you very much. Very exciting past and future. Any questions or comments? Otherwise noted, and we look forward to the expo. Great stuff. Thank you very much. In which case, item 18, Amanda, the board assurance framework, please.
Thank you very much, Chair. So here we have our combined board assurance framework for both Norfolk and Waveney and Suffolk and North East Essex. And this will be the last coming together of both BAFs as we move forward. However, having said that, we will be taking all of the current risks presented in front of us today, and we will be incorporating those into our new BAF for Norfolk and Suffolk from the 1st of April. Since the last board update on our BAFs, there have been collectively 6 that have positively been reviewed and downgraded, and they are reflected in the BAF presented today. But I think you wanted to keep me brief, Chair, so I will leave it there. More to come as we move forward with one BAF moving forward. Very happy to take any questions.
Amanda, thank you very much for being so concise. Howard.
Yeah, I've notified Amanda of this, but so BAF risk 25, that's the finance risk for SNE. It's not the latest version that was approved by the Finance Committee in Common held on the 22nd of January. I've provided that now, so we just need to update the
so we'll update it on the file.
The overall BAF risk score is the same, but the narrative is
different.
obviously updated, yeah.
Okay, look forward to the update. Thank you very much. Any other questions or points, or shall we say received and noted, and we look forward to next year's new BAF, shall we say, for Norfolk and Suffolk? Agreed? Wonderful, thank you very much. Item 19, committee reports. There are 5 in front of you. There are 4 information, but of course the opportunity to ask any questions that you may have as a board. If there are no questions, shall we say received and noted? Received and noted, thank you very much. Item 20, the Equality Delivery System V2. Again, Amanda, I think you're proposing to go straight for questions on that, if there are any.
Indeed, I am. Thank you, Chair.
Are there any questions or points? Otherwise, received and noted. Agreed. That takes us then on to questions from the public, and these are the SNE-related questions I referred to right at the beginning of the meeting. We have 4, 2 from Mr. Dooley, 1 from Mr. Bence, 1 from Mr. Sharp. I think, Simon, are you reading out all of them? Is that the way we'll go?
I am, yes.
Okay, over to you for the first one then, please.
Okay, the first one from Anthony Dooley. Does the ICB consider that the government's intent to increase the time overseas workers will have to wait to apply for indefinite leave to remain in the UK from 5 years to 10 years, and that includes health workers, is compatible with your claim to be committed to equality, diversity and inclusion? And what do you regard as the impact that this is likely to have, should this proposal be implemented, will be on staff morale and workforce planning?
Thank you, Simon. And Amanda, over to you.
Thank you very much. Thank you, Mr. Dooley, for your question. So our ICB is committed to creating an inclusive environment for our workforce and community. We have established frameworks and initiatives to promote equality, diversity and inclusion, such as our Workforce Race Equality Scheme and the Workforce Disability Equality Standard. These efforts reflect a collective commitment to fostering an inclusive workplace and community. And then NHS Employers, the body which represents NHS organisations, has said staff already on a pathway to settlement under the existing rules should not be disadvantaged by these changes. They have also said there is a risk to workforce retention. We will ensure any risk to workforce retention is minimised as much as possible. Thank you.
Amanda, thank you very much. Back to you, Simon, for Mr. Dooley's second question.
Okay, so the second question is, will the newly formed Norfolk and Suffolk ICB as commissioners ensure that the disgraceful treatment of councillors over the past 2 years, with the decision of NSFT to outsource a service to Mind in Norfolk and Waveney that has failed to pay those councillors, the NHS rate for the job will end, and those councillors affected will be paid the NHS rate for the job, including back payment entitlement? If so, will the new ICB make explicit that it will insist that future contracts to the likes of NSFT shall not be outsourced, in line with the government's promise before the general election to reverse outsourcing in the health service?
Thank you, Simon. And Faisal?
Thank you. Thank you for the question. NSFT is aware of the ongoing pay issue involving councillors at Norfolk and Waveney Mind working in talking therapy services, and we've met with Norfolk and Waveney Mind and Unison to discuss the issues that have been raised. Just to say, we absolutely understand and respect the concerns raised by the workers and their representatives. As a healthcare provider, we're committed to ensuring that everyone involved in delivering high quality care is treated fairly and with respect. The councillors are not NHS employees, and Norfolk and Waveney Mind, as the employer, is responsible for their employment terms, including pay and working conditions. Having said that, NSFT will continue to liaise closely with everyone involved and do everything we can reasonably do to support and facilitate a resolution in this matter. Our priority is to ensure that our service users continue to access safe and effective talking therapy services to support improved well-being and quality of life.
Thank you, Faisal. Simon, back to you for Mr. Bence's question.
So the third question comes from Tony Bence of Prostate Pathway. And Tony has sent a paper regarding the sustainability of our primary care prescribing budget as part of the prostate cancer pathway. And he said this submission highlights the catastrophic financial impact of late-stage prostate cancer diagnosis on primary care budgets, and also advocating for a shift towards a more open approach, such as that being adopted by the Australian wider invitation model. As a local constituent and a 5.5-year survivor of asymptomatic Gleason 4+3, I am living proof that early detection prevents the transition to high-cost metastatic management. There is a growing movement towards an optimal diagnosis, but there are less obvious concerns being expressed over the longer-term financial burden on primary care. I respect that this briefing be included in the papers for the 25th of March meeting, specifically addressing the board's duty to meet the National Cancer Plan's 75% early diagnosis target while managing any associated liabilities.
Thank you, Simon. Frankie?
Firstly, thank you, Mr. Bence, for taking the time to submit your paper, and we're very pleased that you're continuing on your own recovery journey. We will ensure that our Cancer Board receives the paper and considers its contents in detail. Cancer screening policies are very carefully weighted and decided nationally, and as you've highlighted in your report, for many cancers, treatments are easier, cheaper and more effective when cancers are caught at an early stage, as I alluded to earlier on just today about lung cancer screening. That is why the NHS screening programmes try to detect various cancers before they've started to cause symptoms. Although we have engaged in the recent call for input to review this, the national position remains, though, that mass screening for prostate cancer is not recommended. In line with your paper, though, we do continue to encourage targeted screening of high-risk individuals, in particular people over 50 from a Black ethnic background and those with a family history of prostate cancer, and we strongly recommend that anyone with symptoms of prostate cancer should contact their GP team to discuss and to consider screening.
Okay, thank you, Frankie. And then Simon, back to you for the final question from Mr. Sharp.
So this one is from Nick Sharp, and he's written, I work for the East of England Ambulance Service as an ambulance care assistant for the North East Essex Patient Transport Services. He writes, as you will be aware, after the tender process was completed for the SNE PTS contract from the 1st of April 2026, the private ambulance service company HTG will be responsible for PTS in this area. I am, along with many of my colleagues, currently going through the CUPE process so that I can remain employed in my PTS role. The reason I am submitting this request topic for your attention is that I have major concerns regarding the current state of the CUPE from East to HTG. The whole process has been stressful with very little information being provided by the new provider, not until recently, just weeks before the CUPE process is set to be completed. After one-to-one engagement sessions between staff wishing to CUPE and the new provider, we were advised that HTG would be honouring our existing working patterns and shift times for at least 6 months. This was a major relief to staff who had been concerned that this would not be the case. In addition, many staff were also advised which of the new Essex bases they would be working out of. However, since then, we, the staff wishing to CUPE to HTG, have been advised that we must adopt a brand new 16-week working rota pattern effectively immediately from the 1st of April. Many staff have been advised that they are to work out of a new different base station to that they had agreed with HTG during their one-to-one meeting. Concerns are that unless the CUPE process can be managed in such a way that it allows for staff to have their current terms of employment honoured, then there are going to be massive service level issues for the ICB to have to deal with come the 1st of April. Ideally, we would like to request the ICB's involvement in the final days of the CUPE process in order to ensure a smooth transition of service. I hope that this request for the ICB to help conclude the CUPE process can be accommodated. And that question has been summarised. Thank you.
Thank you, Simon. Richard?
Thank you for raising that, and I'm sorry for the experience that you're raising on behalf of your colleagues. So just in context, we're the commissioner of the service in terms of Suffolk and North East Essex, and we have a clear role and responsibility to facilitate the information exchange between the outgoing and the incoming provider as part of the process. And our team has met regularly with both of those providers to ensure that they're discharging their primary legal duties, to inform and consult with staff on the 2P arrangements to ensure that there is continuity of service, which is so important for our patients. We're not able to get directly involved in the transfer process as staff are not employed by the ICB. However, we have, as part of our oversight arrangement in terms of moving from one provider to the other, been in contact with their senior team, particularly their Chief Operating Officer, to ensure that they're addressing the issues raised as part of the CUPE process, part of which has just been raised, and that particularly that risk that's just been highlighted of any gaps in rotas as part of the go-live date, and how that's going to be mitigated if that is the case. The ICB understands that HTG are working with East employees on an individual basis to address individual concerns, but we're picking up further with the team there.
Okay, thank you very much, Richard, and thank you, Simon, for reading those out. So, colleagues, any other business? None has been notified to me prior, but now is your opportunity to raise a hand. No other business raised, in which case, at 16:12:13, you're 7 minutes ahead. Well done. I think we'll close the meeting 7 minutes ahead, saying goodbye to Norfolk and Waveney ICB, Suffolk and North East Essex ICB. It's our last meeting in public today. Our next meeting should be the inaugural Norfolk and Suffolk meeting on the 1st of April. So look forward to seeing you all then, and thanks for everything you've done over the ICB history to date. Meeting closed. Thanks very much, everybody.